And good morning, everyone, and welcome back to Perf Web Webinar Series. I'm your host, Joe Basha. First and foremost, as always, I want to thank you all for your continued support in making Perf Web your #1 perfusion education hub. We would also like to remind you that every one of our shows, broadcasts, webinars have been approved for Category 1 CEUs by the ABCP. Please refer to our website, www.perfweb.us, for a complete list of ABCP-approved webinars, for webinar registration, and for the amount of Category 1 CEUs that will be awarded. As you know, our programs are free for everyone to watch. You only pay if you need that CEU certificate, because we want our colleagues, we want you to be a participant in this and for us all to learn together. I think basically at the end of the day, it is about collaboration, and we want everyone from over the globe who may be participating in these programs to join in and be a part of it. Also, please give us a few days to email you your certificate, except for Claire. Claire, if you're watching, I promise you we will eventually get you your CEU certificate. Apparently, we must not like you, I guess. Hopefully, you'll call in and tell us about that. We will email them to the address that you registered for the program with. Okay, click the red subscribe button right here. Roger's going to show it to us, and be a part of our Perf Web family. The red subscribe button, as I said, is right here. Go ahead and click it now if you haven't already done it. Next, click the bell icon next to the subscribe button to receive notifications and updates. We will constantly be working on improving basically the end user, your experience. And for those colleagues that cannot make it to a meeting or for whatever reason, as seen here on our flyer, you will be able to acquire all of your required ABCP CEUs right here with us. As of now, we have 2 ways in which for you to participate and to interact with us. The first way is the YouTube chat feature. The feature is found on the right side of the broadcast, but if you're watching this in full screen mode, you'll first have to exit that, and then the chat box will appear. You also must have a Gmail account. So during the commercial break, if you don't already have a Gmail account, please go get one. It's very easy to do, of course. All that we ask is when you chat with us, please include your name, where you're from, and what you do. I'll be monitoring the chat right here during the program and during the broadcast, and be able to respond to you via chat and also communicate what your thoughts may be to the panel or to other people who may be on the phone. We have also a dedicated phone line sitting right here that is accessible when I say the phone lines are open. And you'll see this message saying phone lines are open now. Please wait for that. The telephone number, as you can see, is 281-738-7906. Go ahead and write that down. So if you have a good question or want to make a comment, please call in and be live on the air. But please wait until I say, reminder, that the phone lines are open and you see this notification. If for some reason I cannot answer your call because someone else may be on the line, please try again. If you don't try again, I may even call you back. I really want to hear what you have to say and what you think. Also, when you do call in, please turn the volume on the device you are watching down. There's a normal 20 to 60 second delay over the web, and if your volume is turned up, it will be very distracting. Your call will be live, but the viewers will hear you around 20 to 60 seconds later. In fact, you'll see yourself 20 to 60 seconds later. So, welcome to our show. Again, I am your host, Joe Basha. Please allow me to introduce you to our esteemed panel for this morning's program. To my right is my immediate right is Rodel Ibus, perfusionist extraordinaire. He has a tremendous amount of experience in all facets of perfusion. And I think that he is going to really provide a lot of good insight, even though I'm going to argue with almost everything he has to say today. But he's an excellent faculty. And to the far right is Patrick O'Toole. Patrick O'Toole also is a perfusionist extraordinaire. I'm not sure which of the two of them is actually more extraordinaire, but Patrick comes with a wealth of experience, both in the clinical setting and in the industry setting. and he too is going to have some really, really good insights today. So with that said, we're going to get this program started, and we're going to go with the first discussion, which is actually WRAP versus ultrafiltration. As an interesting note, Nathan Badair was actually scheduled to be here. Now, Nathan told me somewhere along the way that, well, gee, Joe, I didn't know you were serious. Nate, if you're watching for any reason, no, I was very serious about this. And so Nate actually has it all, I'm just joking, all kidding aside, had a conflict with a personal matter with his family that he had to manage, and so he's not here with us today. So with that said, Rodell and Patrick have agreed to fill in for him. So it's going to be a 2-against-1 scenario. Rodell and Patrick both truly believe in WRAP. Me, Joe Basha, your humble host, really thinks the only WRAP that should exist, and even probably should even exist, is the rap that you hear from Eminem or Jay-Z.
Or
So
Nate Dogg. Nate Dogg.
And Nate Dogg. Nathan, that's Nathan Badair's name is Nate Dogg. So with that said, let's let the argument begin. Rodell, Patrick, which of you chooses to go first?
I'll go first.
You're going first? Okay, so we're going with Patrick.
All right.
So Patrick, you're on.
So because what we're talking about here is the difference between hemoconcentration and WRAP, I think that WRAP is better in the reason that, think about some of the things that come off in the ultrafiltration process. There's heparin, some heparin. There's plasma-free heparin, which you know a lot about because you wrote a paper on it.
Exactly.
There are inflammatory response, mediators that come out, and so that's a good thing. But in general, if you're just simply taking fluid off of your circuit before you go on bypass, I think you're better off than taking off a bunch of other stuff that you've got to replace. And that's where I stand. I mean, I've seen over and over when I go on bypass that WRAP is very helpful. And I will even go as far as to say that it's worth the risk to do arterial WRAP, which we can talk about some of the situations we've seen in our practice, and venous WRAP, because I know there's dangers to arterial WRAP.
Mm-hmm. Now, just in case anybody is watching the program that doesn't know what WRAP is, and I probably should have explained that to start with. So when you have a heart-lung machine set up, in case anybody's not a perfusionist, you have to prime it. You don't want to have air in the system for obvious reasons. And the minimum is probably about 1,000 cc's. It could be 1,000 up to 2,000 cc's, depending on the person's circuit. Would you agree with
Absolutely.
that?
1,000 is get a liter off, is what you're saying?
No, to prime the system.
circuit.
Oh,
It's
to
about
prime. Okay,
of non-blood product.
Yeah.
And as a result of that, if you go on bypass, when you turn that circuit on, the patient receives that liter of fluid and dilutes their blood, but then it all mixes and all that kind of thing. If you do WRAP, then you will flush the system with the patient's blood and sort of, I had a diagram of it, but for whatever, I can't show you the little video with the technological failure on my part, but it will flush that with the patient's blood forwards and backwards before you go on bypass, and that reduces that just eliminates that liter of fluid. Okay, so that's what that is. So Rodell?
Right. So, before I came here, I was rapping for most of my career. That first year I didn't do rapping because, sometimes it's tough for a new grad to, grasp the gravity of the situation or understand the teamwork that needs to be involved in rap. But I'd been doing it for 15 years with great results. We're using that patient's volume to push that crystalloid back and thus, reducing hemodilution. And that's what my talk is. We're going to talk about that later in one of my other discussions. But I found a couple articles that were quite interesting this morning because, I was doing this on the fly. I'm sorry, Nate. But, this is on the Brazilian Journal of Cardiovascular Surgery, and it talks about the efficacy of retrograde autologous priming in the cardiopulmonary bypass circuit. Let's see. And and it resulted in something quite interesting. We talk about the significant values, and if you see here, the hemoglobin values did not differ between the RAP group and the non-RAP group, but what was interesting was during cardiopulmonary bypass, the hemoglobin values and the hematocrit values were significantly increased in the RAP group than the control group, which is the non-RAP group, which is just the crystalloid group. So that was quite interesting.
You can point with this too if you want to.
Very nice. Oh, maybe it's not on.
Let's see.
Maybe it's not on.
It's not working.
That's okay. The joys of live TV. And that was quite interesting to me. And then I found this other paper. It's again talking about the efficacy of RAP. Let's see. And I just have a few charts here.
Can you read it?
Yeah, my eyes aren't so good since I've turned 40, but nonetheless, I can read. I can read most of it, and hopefully you can see it while you're viewing this on the web. Maybe not statistical values that are just eye-popping, but in the control group, for me, 24-hour chest tube drainage is a big deal because that equates to transfusions. The surgeon looks at like, hey, what did you do back there? What did you do to my patient? Did you give him blood? Why didn't you do this or do that? So, I mean, that's 100 mLs of volume that got out of the patient. So, and that could very well translate to a lower hemoglobin and thus getting a Paxil. And we'll talk about the deleterious effects of Paxils in my next talk. But that was quite interesting. Patients in the control group were transfused more. I mean, look at, if you see there's a 24 versus a 9 in the RAP group. Mm-hmm. And then, so that was quite significant to me. And not that this is a huge amount. Patients transfused with other blood products, not just your RBCs, your FFP, and your platelets, because we're also talking about increasing your colloid osmotic pressure by not hemodiluting them. I mean, you're diluting your albumin, you're diluting your.
That's a good point.
Yeah, you're diluting your inotropic drugs, you're diluting and I'm sure that some of you out there are actually priming with mannitol, with heparin, your bicarbs, and if you're not hemodiluting those drugs in your prime, you would think that it would have more efficacy if you're not diluting those drugs. You're not pulling those off.
You're trying to convince me?
So I am trying to convince you because I have 15 years worth of experience with RAP. Because RAP is considered controversial. Mm-hmm. With a group of perfusionists. I mean, actually, with most perfusionists. When I go to conferences and we talk about RAP, we're like, oh my goodness, you RAP. Why do you do that? There's just an insignificant amount of volume that's taken off.
It's not insignificant.
But it's not insignificant.
We can get 700 cc's off
yes.
if we do it well.
If you do it well.
700 cc's. Mm-hmm. That's huge.
Mm-hmm. And there's
I can't wait to hear your side of this.
So it's quite interesting too, and it's almost an issue with how you communicate with your team. Like, well, I do hear, well, anesthesia just gives it right back. This hypovolemia, this hypotension. Well, we can do that, but we can also mediate it with phenylephrine, which is what we did a lot of. Mm-hmm. I mean, if you talk to the surgeon, say like, hey, I'm just wrapping. He goes, okay, not a problem, just bump them up. I mean, I heard that a lot. And that gives us that autonomy. It gives us, hey, that communication with that anesthesiologist or CRNA. So that's a quite interesting thing. And I am trying to take care of this patient from inception till when they discharge. So I'm not just looking at this bypass run with RAP. I'm taking this volume away from this patient so they don't have to see that hemodilution. So they don't have to take or get red blood cells, whole blood, cryo, all these different types of homologous blood that is hopefully unnecessary. And I think, let's see. So, and then we look at this, and this is quite interesting. You look at, and what do we see here? My eyes aren't so good.
Exactly.
You're right.
Exactly. You could watch it on your computer too, so you could actually see it.
Yeah, that's very good. That's a good point. But again, it's quite interesting where we do get to talk to our team about RAP. So it's just another piece of this surgery that we can talk about. So it
And I'd
just
like to
opens
weigh
up
in
the
on
channels.
that too.
Oh yeah, we're gonna be weighing in on this for a little while here.
Well,
I think so. But
yeah, you go first.
no.
Okay.
Really,
So
wait.
I got 2 points I want to bring up. The second one I'll save for later, but it's pretty impressive when you got a patient who's say 80 kilograms and they've come into the OR with a crit of 27, and you can say to the surgeon, "I got this. We're not going to use any blood. We're good." And if you think about this is really the argument. Well, we'll figure out what the argument is here if you're going to come down on the side of hemoconcentration. But as far as RAP goes, let's say we RAP and we go on and our immediate hematocrit right away because we RAPed is say 20 as opposed to 15 or 16. When you hemoconcentrate, it's going to take you, even at the fastest rate, it's going to take you 2 or 3 minutes to get that that volume off, to get that crit back up. If you go on and it's suddenly at 16, you're going to get back up to 20. So what happens during that 3 minutes as far as to the brain? And that's something that that's why I would say RAP is better than hemoconcentration, because of the immediate effect that we're going to have on the hemoglobin. Answer that.
Now,
He's holding back.
Did you have any more?
No, I
You
mean,
have
so
some more slides, right?
we're showing this graph, and we're showing the difference, with the hematocrit during the whole bypass run, and even hematocrit at discharge. We see that graph where the pre-op hematocrit is the same, obviously, because we're not on bypass, and then there's the pre-bypass. It's fairly close. I mean, you get some hemodilution because the anesthesia has to give their meds through their IVs, and then you go through the pump run after the RAP, and you actually see the post CPB hematocrit go up. Probably because we didn't have that that volume that was given. I mean, hopefully that perfusionist or this group was judicious in the volume administration.
Yeah, and good point. But let me just ask you: is that control? But I can't quite read all of it. But just so we understand and we're all on the same page here, that's comparing it
To non-RAP.
non-RAP, but not
Non-RAP.
ultrafiltration.
Correct.
That's not these comparisons you're doing are not with ultrafiltration.
Right, correct.
They're just a control, no RAP,
No RAP.
versus RAP.
Right.
Okay, fair enough.
But I'm just showing you that, like, hey, it's a viable technique within the perfusionist toolbox.
Yeah, I'm really curious out there if anybody could send it via chat, or hopefully people will call in. I want to get y'all's opinion about this too, and know whether you use RAP within your practice or whether you just use ultrafiltration within your practice. I'm really pretty curious about that. So make sure you do either chat or call in. And oh, one other thing I forgot to mention. We're dual streaming over not just YouTube, but Facebook. I forgot to mention that in the
right,
opening
Facebook Live.
remarks. So we're actually on Facebook Live right now as well. In fact, it's being watched. So that's perfect. I forgot to mention that. But so just so everybody's on the same page who's watching, this is not comparing it to anything but either
A
RAP or
control group.
nothing.
Correct.
Okay.
Correct. Well, I couldn't find anything that was really a comparative with hemoconcentration and RAP, because you know what? We also talk about with that lack of volume, quote unquote, we may not have that volume to hemoconcentrate. You know, we've taken that patient's volume back, and you know we don't have that extracellular.
Oh, those are the special cases when,
Yes.
in particular, when I really disagree with RAP, and I'll explain that too.
Yes.
So, did you have any other slides?
No, I believe
That's
that's
it? That's the end of your slides?
That's the end of my slides.
We could do a study on that.
We could do a quick
as group,
study on it.
but
I
we've
would
got
love to
plenty
do
of
that,
cases
actually.
to
Well,
do.
you know, and I would
we could
welcome-
compare RAP and hemoconcentration and do a study. We could do that.
I think that would be outstanding, and I think if it just isn't about blood transfusions, it's about, you know, all kinds of things. Renal failure. It's about, you know, length of intubation time. It's about stay in the ICU.
Right.
It's about postoperative bleeding. It's about length of time in the hospital as a whole, not just, you know, transfusions. So what impact is all of this going to have? And I think, you know, the way I view this whole thing is that it's a risk to benefit ratio. You're going to open your venous line and you're going to drain blood back. You might do arterial line first and you're going to drain blood back. It doesn't matter which direction we choose to go first, but both of those are fraught with, in my opinion, potential pitfalls and dangers. You can take off too much volume at any one time. Something could happen. Likelihood is probably slim, but it could. I've seen people wrapping through the arterial retrograde. Personally know the experience. It wasn't me because I won't do it. But they actually entrained air around the purse string sutures and got air in the arterial cannula by retrograde priming the arterial line. You talked about a patient that you might not have enough volume in which to ultrafiltrate, but yet you're going to now drain that patient of all of that pump circuit, and you have to involve anesthesia, giving neo. The blood pressure's probably going to go down, and they're going to get it back up again. But you were worried about my 2 or 3 minutes to get my prime off, but in the 2 or 3 minutes that you're doing that and you're pushing neo and you're artificially creating a blood pressure with terribly inadequate perfusion, how could that be any better? Now, you go on pump and you have, let's say, a bit of hypovolemia, and or let's say in your scenario, you go on and you diluted the hematocrit a little more than you wanted to, you can flow that. It's about O2 delivery. So when you talk about draining this patient of 25% of their blood volume, potentially up to maybe 30, depending on the patient, maybe only 20, depending on the patient, then I think that what happens is we have no idea what's happening. We're not monitoring TCD.
True.
You don't know that the cerebral perfusion pressure is adequate. Anesthesia can give anybody a blood pressure, but we all know, and I don't mean to be redundant or repeat myself, blood pressure and perfusion are not equal. You can have a great blood pressure and no perfusion whatsoever. So for me, it becomes a risk to benefit ratio. What is the risk of potentially hypoperfusing the patient, and what will the effect of that be by draining that blood to displace the pump prime versus going on potentially having a lower than we're comfortable with hematocrit and within 2 or 3 minutes ultrafiltrating off that prime. One seems inherently much safer than the other. So how do you address my concern about that? Because, you know, and make no bones about this, I am 100 and a billion% against wrapping anybody.
Even the venous side.
Even the venous side, completely
Because,
against it.
you know, you don't have the risks of entraining air on the venous side. I
Right.
mean, you can entrain air if you do that, but it's not going to be a serious problem for the patient. I think there are some inherent risks on the arterial side. You got to make sure you do it right. Don't leave your vacuum on when you do that, and you know, do it slowly, that sort of thing. But I think the venous side, you know, in our circuit, our venous side is 300 milliliters. That's what it is, and that's worth it to get it off. And you know, I'll be honest. What I do is I hope none of the anesthesiologists that or surgeons that we work with are watching this right now, but what I do if I'm going to wrap, if I've got that patient who's 80 kilograms, 70 kilograms, and they already have a low hematocrit, is I'll put a little bit of neosynephrine in the prime, so that when I wrap and the minute I go on, they're pushing that volume back to me, and I think it helps. I mean, I think it's
So do you think it's better to have, in all seriousness, a hematocrit of 17 or 16, hopefully not that low, but I guess it can happen, for 2 or 3 minutes? Or is it better to have an SVR of 3,000 for
I don't
2
have
or
an
3
SCR
minutes?
that low because I've already
No, that high.
hit him with some neosynephrine.
2,000. That high. Normal's about 1,000, so
Yeah.
I'm just doubling it.
But I don't really have a low SVR already because I've already hit him with some neosynephrine in the prime. So the second I go on, their SVR is back up.
Okay, but if
I'm
you're
not waiting 3
taking
minutes
blood
to
out
give
of a
them.
patient, what is the normal physiologic reaction to the arterial circulation? It constricts, right?
Sure.
So your SVR is already going up because you're taking volume out.
Right.
So then if you go on with Neo, now your SVR is even higher. So my question is, what's better, giving a vasopressor and raising the SVR to twice normal, or having a little bit lower hematocrit for 15, 16 even, for 2 or 3 minutes? I mean, that's my fundamental question.
Yeah. It's there's no way to tell because, like you said, we're not really
Does it
monitoring.
give you pause? Does it make you concerned? I mean, do you know? If you don't know,
I don't know what happens.
but
It's
does
true.
that give
We don't
you,
know. We
But
don't
does
know.
that give you pause?
It's a good argument.
Are you rethinking your position?
I'd have to have some sort of concrete evidence,
But are
which
you
is another
rethinking
study.
your position?
Okay, yes, I'm doing
Okay,
that.
well, my job is
I'll
done.
give you
My
that.
work is done. My work is done here. In
Right.
fact, I can
No, I-
retire.
I
I
think-
feel
no,
like
you
I
can't
can
retire.
retire for perfusion now. I'm done. Done. I have converted Patrick.
You did
to
not
a
convert me. I
non-rapper.
said I was rethinking my position, but I'm not changing. No, not yet. I would need. This is a great study, but we'd have to have some additional monitoring, and I think it'd be a very good study to have.
Stephanie has a chat. She says, I have to take my glasses off to read it. In low volume small patients, I've seen that you can get the 700 off with RAP, but you can't always get that same amount off with hemoconcentration
Correct.
after you go on. Oh.
Yes. So this is
Now
where
it's
I'm
on.
coming from. No, this is where I'm coming from. So we talk about what we're trying to accomplish. We run the heart-lung machine. We're going to isolate away from the lungs and the heart, correct? So when we have this crystalloid volume and we're not wrapping, we're not taking it off, we immediately push it into the lungs. So it's true, correct? I mean, we're actually pushing this non-heme component straight into the lungs. And we're not going to get it back unless we have some sort of
Well, I mean, how are we
colloid
pumping it
asthmatic.
straight into the lungs?
I was going to ask
What
that
I'm
question
saying is,
myself.
it's getting absorbed into the lungs. I mean, it's
So
got the
you're
largest
saying
surface.
that we're
It's got the
third
largest.
spacing.
Yes.
We're third. So because of the
Yes.
increased hemodilution, we're third spacing.
We are third spacing
and
into the lungs.
increasing pulmonary and causing pulmonary edema.
Correct. And that's my issue.
Off of 1 liter
Off
of fluid.
But if you think about it, we're again isolate where we've got like this ischemic type of lung, where we are not getting that circulation to that lung. We were oxygenating it. It's great. That's our job. But how are we retrieving that afterwards? I mean, it's just sitting there. If we've got a cross clamp time or even a pump time of 90 minutes, that's 90 minutes of this lung just absorbing all of that crystalloid.
How?
The third space.
Are we?
So if we're not increasing our colloid osmotic pressure by taking
I mean,
that,
we're not pumping through it.
we're not pumping through it, but it's just sitting there, and we're not retrieving that blood back. So what I'm saying
So you
is
think
we're
it
third.
sits
It
in
just
the, you
sits
sits
in that space.
in the pulmonary vasculature
Yeah.
and just leaks out over time, over the course of time.
Yeah.
Okay.
I'm just saying. So you're saying
I've never heard that before.
so we're saying we're just prolonged vent times.
Okay, potentially.
Prolonged vent
I would
times.
like, if it's possible, Stephanie, if she's still watching, and if she could call in, I would really like it if she could do that, because I want to know, I want to understand why she thinks what she said. I mean, I'd like to hear about that more.
Let's do this.
Because I think it really speaks to what you're talking about.
Could you go ahead and open the phone lines? Do
Yeah.
put a message on there that we're going to go ahead and open the phone lines. But Kimberly Miller, Kimberly Miller?
Who's Kimberly Miller?
Is this our Kimberly Miller?
The Kimberly?
I don't know who Kimberly Miller is. I feel horrible
Kimberly
about not knowing.
Miller?
Herman.
So Kimberly Miller says that she believes in rap. Kimberly, call in, okay? She believes in rap, but you need participation from anesthesia, and I think that
And
she's
we
exactly
talked about
right.
It's definitely a
Absolutely.
team
You
effort,
have
that's for
to-
sure.
It is a group effort. There's
Yep.
no question that it requires, everybody in the room. The surgeon has to be a little bit patient. He can't be picking the heart up while you're trying to wrap. He
Yeah.
has to be patient and wait. Anesthesia has to be, of course, they have to be ready to give some neo or something like that to help the blood pressure, so they have to do that. But what do you think the probability is? The probability is that anesthesia, knowing what your technique is, we're all creatures of, wanting to just make the case go as easy for us as
smoothly
we
as-
possibly
absolutely.
can. Okay, so we know that we're wrapping. How many do fluid restriction when the patient gets to the operating room and that they're not already way more than what you're going to wrap off fluid loaded by anesthesia, so that the wrap goes so much easier?
Yeah.
So are you only looking at it from hold on one second here, I'll have to swipe it. Good morning, you're on the air. How are you? Who's this?
Yeah.
Good morning, Joe Basha. This is Stephanie Ebus
Hey, Stephanie.
from the Woodlands.
Yes.
Hey. So I just wanted to make a comment about what we were talking about with the wrap before we cross clamp. So I do believe that if you have a lower crit, a lower oncotic pressure when you first go on and you cross clamp right away, then that's what's going to sit in the lungs for that whole period of time of cross clamp. If you can have a higher oncotic pressure, higher hematocrit, I do think it's better for the lungs. So that's one point. The second point I wanted to make, and then I'll let you guys comment. You asked Patrick if he could say if it was better to have a low crit, like 16 or 17, or a higher SVR. I think he's right. We don't know about the higher SVR, but we do know having a lower hematocrit of 16 or 17 is bad for the patient. So I would argue that is probably more important.
Even transiently?
Yes.
Thank you,
It's better
Stephanie.
Thank you.
Why do I feel like I'm being beat up on
Well,
here
listen, I'll
today?
tell you,
This is
Because you
getting
already
pretty
said it was a
rough.
two
I
against
think
one.
that you are
It's
taking.
3 against 1 now.
Wow.
I think you're taking a position that's hard to argue.
Yes.
That's what I think, and I appreciate you doing that, because that's what this is about. Is we need to have what we should do is
No,
have
I don't
somebody
think it's
call-
hard to argue at all. Frankly, I completely disagree with all of you about this. I mean, I'm not taking this position just for entertainment value.
No, you
I'm
really
taking
believe it.
this position because I fundamentally believe that the downside risk potential of performing this wrap procedure far outweighs the downside risk potential to a transient, and it's not every patient that's going to
Right.
have a hematocrit of 15. And if the patient is that anemic, where my liter of pump prime is going to knock their hematocrit down to 15 or 16, well, they're probably a really sick patient to start with anyway, somewhat unstable. I mean, I can make the same arguments here about these unusual cases, responding to Stephanie's concerns, is that, are you going to attempt to wrap a patient who has an ejection fraction of 20% and who is on
right.
multiple pressors already, and you're trying to just, doing not a coding situation, but a
Yeah.
really sick patient.
Yeah.
I'm just asking, Stephanie, would you wrap that patient?
So the beauty of wrap is that you can stop at any moment. So you can start to wrap slowly, and if there is any pressure drop or the patient doesn't tolerate it, you can stop. And also, you can go on bypass right away.
Right,
so
and that's
I really don't think that. At first when we started wrapping, we were very selective on patients. But then we started wrapping every patient because we found that if we did it slowly and we communicated with the anesthesia and the surgeon that there were no issues. Because you can just stop wrapping if the pressure drops.
Right. So again, going back to this 20% ejection fraction patient, and you're the very patient already anemic, the very patient that you really, for those of you who advocate for wrap, want to perform that procedure on, and you can't, and now you just go on bypass. What are you going to do at that point in time? So the sickest of the patients who have the least likelihood of successfully being able to wrap with, you become unstable and go on, and then what do you do? Now I'm just going to go around with everybody.
But I'm saying that
and
rarely
ultrafiltrate.
ever happens.
But okay, that rarely, exactly. So I think the same thing applies to my argument, is that I think that it rarely ever happens. The hematocrit is 15 or 16. Really, it's the difference between going on and having a hematocrit maybe of 30 versus a hematocrit of 26 or 27. Right. Is there really any difference between those two? And is that going to really cause all of these problems that everybody seems to think is going to occur with this liter of volume? You have a relatively healthy patient, no problems, minor little comorbidities, hematocrit of 38% before you go on bypass. Where do you explain to me, so I can understand, how a hematocrit of 27 or 26 or 25 for 2 or 3 minutes while I remove that prime from the ultrafiltrator has less risk and is more deleterious than you going through a 2 or 3 minute procedure of attempting to wrap, potentially having some instability with the blood pressure. I think much more risk of that, in my opinion, and then going on bypass and doing the case with hematocrit of 30. I can make the hematocrit 30 in the amount of time it takes you to wrap the circuit. So how is that better?
Well, I think the point is that when you go on, you're giving that liter of fluid all in one shot. Like in 30 seconds, they're getting a liter of fluid, and I don't think that is good. It's not like they're getting a liter of fluid over 4 hours.
Right.
Well, I mean, that's true. That's true.
Right. I mean, I don't think I've ever seen anesthesia try to give a rapid transfusion of normal saline at a liter, unless they,
but that's because they'll go into cardiac failure.
Correct.
It's a closed system. We have an
Correct.
open yeah, but we have an open system. I mean, I don't think you can compare the two. I mean, we have a reservoir and we drain the heart. I mean, their reason for not giving volume that fast is because they would push the heart over the Starling curve and it would go into failure. But we don't have that concern. That can't happen to us.
Well, I agree.
But that is a fast dilution.
Right.
So are we kind of coming to that this is a patient selection? Would you agree to that?
No, I think
some
wrap
patients should be wrapped and
No,
some
frankly,
patients should not?
No, I think that if anything, I might be willing to advocate for something we used to do in the old days was mix. And I don't know if any of you are familiar with mixing or not, but this is something that we did as a precursor to sort of trying to figure out how we avoid this rush of fluid. But our circuits at the time were a bare minimum of 2,000 cc's of prime. Actually, some of them were up to 2,500 cc's of prime. And we were trying to get away from blood. And we would go on bypass with those cases, and you would have 30 seconds before you actually saw blood going through the line. Maybe even longer than that sometimes.
I believe it.
That's a long 30 seconds.
That's a long
Right,
30
it was
seconds.
pretty, it wasn't good. So what we did in those circumstances, because we actually did see where it had an effect. and we would drain out the venous and pump in the arterial slowly and just keep doing that over the course of time. So we kept the patient's blood volume normal, but only gave, or euvolemic, but only gave small aliquots of fluid until the blood was up to the arterial cannula, and then we would go on bypass. And we called that mixing.
So
Mixing,
was
okay.
this okay? So it was close to the what do they call that? Isovolumetric hemodilution. Is that what we were talking about?
Was similar to that.
Similar
I think,
to that?
I think what you're talking. I think you're talking about when they drain, when they take blood from the patient and put it in the bag. They they have a term.
Yeah,
What is the
we used
term
to
for
do that too.
They call that. What do they call
Well,
that?
you salvage some blood from the venous line.
Yeah, there's a term
And
for
you
it, but I
save
know
it
what
for
you're
after the
talking about.
case.
But,
Yeah.
Okay.
but basically that was the process that we used. But for a 1,000 cc's, 700 c. Really, I mean, it's at 1,000 cc's a liter. I don't really see going on bypass that quickly. I don't really see the physiologic downside to it that you all are addressing here. I don't think it's really been studied. I don't think that I'm aware of, and I don't really have any data in front of me to support that. But I know that in my opinion, and this is strongly my opinion, that RAP as a procedure should be abandoned. I don't think it should be performed by anybody. I don't think it makes any sense whatsoever. I think it makes more sense to ultrafiltrate the patient, have the ultrafiltrator always readily available, go ahead and go on bypass, especially on the unstable patients or the very sick patients, because you get them supported right away. I think that the incremental change in the hematocrit from either going on with RAP or going on post-RAP or going on with just your regular pump prime is, in my opinion, insignificant. Again, not studied. Great study to have done. Hopefully we have some academia people that may be watching, whether on YouTube or Facebook this morning, who can look at that. Maybe that's something they can do. But I think that just for the sake of eliminating a liter's worth of prime in a transient situation for 2 or 3 minutes, the RAP carries with it too much risk, in my opinion, for the potential benefit. And that's my opinion.
Well, let's delineate what are the
So-
risks of RAP. The first one is air entrainment on the arterial side.
If you arterial RAP,
Yes.
And then what the other risks are.
lack of perfusion secondary to having inadequate blood pressure by overpressing the patient.
But then again, we talk
So-
about a transient event.
Right, but
Where,
again, I don't know
again,
which is worse.
yeah,
Is it
which is
worse?
worse?
Which is worse?
Yeah,
But
but-
intuitively, I don't think having an SVR of 3,000 is good for anybody. I think it constricts. It doesn't just constrict your radial artery,
Right.
where you have, but it constricts your renal arteries. It constricts your mesenteric artery. I mean, how many patients have we seen with dead bowel because of excessive use of pressors? Now, I don't think that's going to happen in this circumstance.
Right.
But what I'm trying to say is I don't know which one is better and which one is worse, because there's no good data to really look at. But I do know that I have strong
Yeah.
opinion about it and anecdotal experience, and that tells me this is better than that. So I
I'd
don't
like
wrap
to
patients.
bring up one more point before
Yeah.
I hang up, Joe. So I know we're talking RAP versus hemoconcentration, but in a lot of situations, it's RAP or nothing, because our surgeons don't want us to hemoconcentrate. They want the patient's kidneys to work on their own. So if we don't RAP and get that initial volume off, I do think that we're stuck with that volume, and wrapping would be a better choice.
Well, you just brought up another. You just threw out another point, of course, and that's the surgeons want the kidneys to work on their own. I don't even know how that makes any sense. If you're going to wrap, then you're not providing them any fluid load at all, fluid challenge to stimulate the kidneys to want to pee. You're also creating a relative hypovolemia, albeit for a transient period of time, which of course makes the kidneys stop working. And there is absolutely zero evidence. In fact, there's evidence, quite a lot of evidence to the contrary, that ultrafiltration does not decrease urine output. Look, right now you're
That's true.
performing
I've read those
CRRT.
studies.
So
That's true.
yes, so I mean that's almost a bordering on a non-argument argument.
So, but we're also increasing our viscosity if you're taking away that liter of volume that we were just pushed off.
Well, that's true too. So basically, we have not.
So I mean, we can argue this
should
this
start
whole
over.
time. We should, yeah. I mean, we're 0-0, but we also, also the surgeon looks and turns to us and says, like, hemodilution is your problem,
Right.
So I'm trying to figure out a cheap way to. Oh, that's all right. A cheap way to take off this volume, and maybe there is a perfusion group or company that doesn't believe in hemoconcentration or just finds it expensive or doesn't feel that this needs to be within the circuit because of inflammatory responses or adding just to the overall cost of
It
the
decreases
circuit.
inflammatory response. Ultrafiltration
But
removes inflammatory mediators.
But I'm talking about just, excuse me, SIRS. We're talking about SIRS. So we're talking about like a surface inflammatory response.
Oh,
so
okay. So you're increasing your surface area.
You're increasing your surface area,
I'm
thus,
making the
yes,
call here.
in hemocompatibility, type tubing. But I don't need a surgeon to be saying like, hey,
Your call has been forwarded to an automated.
Let's leave.
I don't need a surgeon to turn around and say like, hey, why did you just push this? It's your fault this hemodilution is happening. But
Your
I
call
only
has been
gave
forwarded.
this liter versus like say anesthesia giving 2 liters prior to bypass.
Uh-huh.
Yeah, sometimes it can be my fault. I will take fault if I don't take care of fluid management. But ultimately the surgeon looks at us and says like, hey, you got to take care of this hemodilution.
Yeah, but there's an old saying: you can't make chicken soup out of chicken.
Stuff.
You know what?
Excrement.
And yeah, that too.
Yes.
And so, hemodilution is our problem. That's true. But if the patient's hematocrit coming into the room is 26 and their anesthesia gives 2 liters of fluid over the course of the time that they're intubating the patient and getting the mammary down, I mean, the patient's getting blood.
Yeah.
I mean, I don't think you can avoid blood transfusion that way.
No, I agree.
I
But
mean, I think
we've
you
done
can, I think
we've
you can
done our due
mitigate
diligence.
it, but I don't think we can just eliminate transfusions.
Right.
Because of either RAP or
Right.
ultrafiltration.
Right. I
Sometimes you
agree.
just have a very
I
anemic
agree.
patient, and you have to
But-
get blood transfusions.
Yeah, but you asked the question of like are you going to wrap that 20% EF? That train
I
wreck type-
wouldn't.
And it's funny, I did. I did. And what I found in most cases, I did have plenty of volume because they were fluid resuscitated.
Right? That's
They're
true.
fluid resuscitated. and
Probably
I-
fluid overloaded.
Yes,
already.
absolutely, already. And if that liter didn't go into that patient, well, there's a little bit less to hemoconcentrate. I mean, I would use both. I mean, again, it's just the perfusion's toolbox. I'm not against hemofiltration by any means. I mean, I believe in RAP.
So Kimberly Miller says, but if you prevent even 1 unit of RBCs, is it worth the risk of RAP? And a transfusion has more detrimental effects
Yes.
than a possible risk of RAP. So Kimberly, I agree with your statement, but again, for me the argument is not the transfusion, because when we go on bypass, I can remove as much fluid as I need to before I do that first blood gas and see what the hematocrit is, so long as I have adequate flow and all of that kind of thing. So, you're removing it beforehand, creating this, not giving it to the patient. I'm giving it to the patient, but removing it in a very short period of time. And I think where this circle argument exists is we don't know which one has more risk or more benefit on either side of this issue. I think that if it were a matter of what Stephanie was saying, is that you know, if you don't have ultrafiltration as an option at all, and you give, you're going to wrap the patient to avoid a transfusion. In that case, yes, I think wrap is a better option than giving that unit, committing to giving that unit of blood to that patient. So I agree with that blood transfusions are inherently bad, and we want to avoid them. However, still necessary. We
Right.
cannot eliminate blood transfusions
Absolutely.
in cardiac surgery.
Right.
Not going to happen. But if you have a choice between wrap and ultrafiltration, I feel like the risk of wrap versus the transient additional hemodilution of my circuit while I remove that from the ultrafiltrator is not as good, that the ultrafiltration is better. And that's my argument. My esteemed colleagues here at the panel, and apparently you too, and
Everybody
Stephanie
else
that's
calling
called
in.
in, and the rest
Everybody
of
else
the world
calling in.
feels that I'm, you know, the second coming.
It'd be great to hear from somebody who's on your side.
Yes.
You know, if there's
Yeah.
anybody
Well,
out there.
you know,
who-
they're-
Nobody's
they
going
are
to
present
all,
an argument.
you know,
Nobody's
which,
calling to be on my side.
which is actually quite funny because I find more perfusionists against the wrap.
you
And
know.
that I know of. I mean, I practiced in Tuscaloosa for a short period of time, and that perfusionist was against wrap, which was quite interesting to me because, you know, again, I've been doing it for so long that it's second nature to me. It's me talking to the surgeon, me
You talking
talking
about
to
Mark? Mark was against
Right.
wrap?
Yes.
Mark, I know you're probably
Mark
not
is
watching
probably
right now,
asleep.
but
He's on
Mark-
Mountain Time.
Yeah, he's on Mountain Time, but Mark, I knew there was a reason why we had such a close
Yes.
affinity to our
Yes.
to each other.
Yes.
What were his reasons for being against?
The same as Joe's. It's a risk benefit type thing to him. But when I did this, where I practiced before in Detroit, we actually watched. I personally watched these patients from pre-op all the way to discharge, and I watched their blood product utilization from the ICU and on. And I found that we reduced our blood product usage because of all of our different techniques with fluid management and adding wrap into the actual blood conservation plan did actually show that, you know, hey, this is an actual legitimate procedure to perform. And this was against off-pump surgeons. You know,
Oh, yeah.
surgeons who, you know, don't use our cardiopulmonary bypass circuit. You know, they're not seeing this quote unquote liter of volume, 1200, whatever it is your prime volume is. So we actually found that they were giving more blood products than our cardiopulmonary bypass patients. So that is quite interesting. I don't have that data, but you know, and you know, it's institutional data that I'm sure they don't want to share, but you know, I took care of that data and I saw it.
Okay.
So, and I
Very
reported
good.
it.
Well, I think that I'm getting a 5-minute warning signal here. So I think what we're going to do is, unless there's any other questions, let's how about if we go to commercial break? We're going to take about 5 minutes maybe, and then we're going to come back and we're going to hit it with Rodell's presentation on how low can we go on the hemoglobin, optimizing the hemoglobin for our patients. I think this is going to be a very informative discussion. You know, blood transfusion management is still huge. In fact, Stephanie and I, who called in earlier, had a meeting yesterday with a commission on Jehovah's Witness patients in our area where we work to talk with us about how we operated our circuit, and they were very, very, very pleased with what we are doing for every patient, essentially. There's a few little different things that we did for the Jehovah's Witness community. As we all know, we have that are required to respect their faith. But at the end of the day, they were extremely pleased with how we're conducting our procedures and what we're using on those cases. And but they, you know, they're very strongly against transfusions. So I think, knowing what you're going to talk about right now, I mean, transfusions carry with them, you know, horrible risks. And I think that if we we all need to treat, I think, every patient like a Jehovah's Witness at the end of the day. So
Absolutely.
let's go ahead and go to commercial. We'll come back to Rodell. Let's take that 5-minute break, use the restroom, get your phone primed up to call in, whatever it is you need to do, and we'll look forward to seeing you back in 5 minutes.
Imagine trying to drive a car looking only through the rearview mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. With other systems, periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Light-emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration, or visit terumo-cvs.com.
Oh, and welcome back to the program. We've got director confusion back there. Not sure what's going on, but welcome back. And we're going to move right into Rodell's talk on how low can we go optimizing hemoglobin. Rodell.
Okay. So it's an interesting subject. I mean, we all go on bypass and we all have issues with hemodilution, you know, and we talk about hemodilutional anemia. And that's along with it, you get acute renal failure, poor tissue oxygenation, and prolonged ventilator support. You know, that's all in with the hemodilutional anemia related. And what I went through is going through a bunch of articles talking about this hemodilution and transfusion. And this one is talking about the impact of a hematocrit of 20% during a normothermic cardiopulmonary bypass, which is quite interesting. This study is normothermic. You look at all the other studies, nobody really talks about the temperature. Everybody goes down to your 32 degrees. Nobody really accounts for that temperature difference. And it was a randomized study. And is there, you know, we also talk about the minimum safe level of hematocrit to maintain the oxygen delivery during bypass. This study was prospective, randomized, and it had controlled data. Patients were subject to the normothermic CPB at 35 to 36 degrees Celsius, and they were observed until discharged from the ICU. And outcomes were measured and calculated with a whole body oxygen delivery, consumption, and the clinical outcome. Primary outcome measures of this trial were calculated with whole body oxygen delivery, mixed venous blood, and lactate during CPB and at the end of surgery and the ICU. The patient population wasn't as high in this actual study, but it was still quite interesting. It was 54 patients where crit of 25% and crit of 20% in 26 patients. Let's see. I don't know the great order that Joe is. And statistically, the outcomes were not different between the groups. No myocardial infarction was detected in the groups as well. So, which is quite interesting, and we talk about like the difference between 20% and 25%. You know, and you hear that the 20% is going to get transfused. Well, this actual data shows like, hey, we don't need a transfusion at 20%. There is not a statistical difference with the oxygen delivery. And we also we talk about like that tissue perfusion. And this data shows that during normothermic a normothermic situation, there's no statistical difference. So that was quite interesting, 20%. You know, how low can we go?
Well, you know, I mean, 20% seems to be like a trigger number out there,
right?
Around here. I've worked in other areas where the trigger number is 18.
Yeah.
And so I don't like the idea of trigger numbers at all, because I think there's a lot of other aspects to who gets transfused other than the percentage of their hematocrit or their hemoglobin. It's more about the patient, because the older the patient is, you know, you're probably, that's a factor. You know, you have an older patient, they probably are going to have more issues with the blood flow to their brain just from age, you know, from having more vascular disease. And so, you know, those patients, maybe 20% is the number that you trigger to give a transfusion. But then there are other patients who, you know, we're fortunate enough in the area that we working around here that a lot of our patients are in their 50s and 60s.
Right.
And they don't need a transfusion at 18%. I don't think they do.
Yeah. So in this, it was quite interesting. The hematocrit as low as 20% during normothermic was not associated with higher incidence of acute renal failure. Again, if in the earlier slide, we were talking about the hypovolemia. So again, it wasn't, that statistically was very interesting to me. The oxygen delivery to the kidneys was maintained since the post-op creatinine levels and urine volumes and the usage of the loop diuretics weren't shown, but it was not significant between the 25% and the 20%, which was, again, interesting to me. It's like, hey, maybe 20 is the lowest. Let's see here. So this here is a large prospective study, the hemodilution during cardiopulmonary bypass and as an independent risk for acute renal failure in adult cardiac surgery was that's okay. I was just going to speak about this.
Okay.
And going through all the literature, this often came up. This talked about the risk of the acute renal failure, and it did show that it wasn't really much of a acute renal injury, and it supported the data that was in the previous study that I just talked about.
So in this, make sure I understood what you just said. You're saying in this circumstance, in this study, hemodilution during cardiopulmonary bypass is an independent risk factor
Right.
for acute renal failure. They concluded it was.
Correct.
Okay.
Correct.
But what? Okay.
So what was the question, Joe? I'm sorry.
To what degree of hemodilution?
Oh, to that 20.
To that 20,
which is a large prospective study, and it was again quite interesting. This really going through all this literature really kind of changed my mind about certain transfusion triggers. And things like that. I mean, I've always had them, but now it's a little more of a solid base. I'm trying to.
So you from the studies that you've read, you're a proponent of transfusion at 20%?
No, I'm actually not. We have to look at the whole picture, and I'll get to that whole picture in a second, because there is a guideline that the STS that projects with a tolerable level of hemoglobin.
Don't forget you have to do
Yes,
this one at the same
yes,
time.
thank you. So this was quite interesting. I mean, this is a editorial. Is the patient or the physician that can't tolerate the anemia?
That's a great one, yeah.
It is. It's actually a prospective analysis of 1,800 patients non-transfused during coronary artery bypass surgery. Many a time where I've come to the OR and the patient's SVO2 is high. We've got excellent diuresis, well over 1 cc per kilo per hour in a 50-year-old patient, but the anesthesiologist is uncomfortable with a 7.1 hemoglobin. They have this, I wouldn't say archaic, but a trained notion of, hey, 7 is not good. We need to transfuse. I mean, are they thinking about the deleterious effects of red cells? And what do I have in my toolbox to say, like, hey, doc, I can't transfuse this patient because this, and this. I need a tool to tell me that, to say like, hey, we're okay. There's very many times where this anesthesiologist or even surgeon, mind you, say like, no, just transfuse, much to my chagrin. But again, I'm just a perfusionist and I am following orders, but I as a patient advocate does not want to transfuse. If you guys were having surgery, I'm going to do everything in my power not to transfuse, only because I know the deleterious effects of red blood cell usage.
And I appreciate that, but don't rat me either.
You wouldn't know.
You never know.
You would never know.
You know, something else about transfusions, which is out there and is well studied, is that, and I hear this all the time, well, we've already broken the seal on blood products,
Right.
so let's just give more. But
Right.
one transfusion is bad.
Yes.
2 transfusions is not double bad.
Correct.
It's 100 times badder.
Yeah.
Yeah. Yes.
I know badder isn't a word. I just
Batter
use
is
that.
not a
But
word.
the reason is because you've got antibodies that are going to react against antibodies from the first one and the patient's.
Right.
So, yeah, transfusion's bad all around.
Yeah.
I totally agree.
Yeah,
Yeah.
nobody can argue against that.
Nobody can argue against that. But we will talk about it. So this next study is what really shaped my practice. It's a study that we used to give the students when I was teaching. Our clinical coordinator would always give this study as homework, talking about transfusion and lowest hematocrit on cardiopulmonary bypass. It's the Ranucci study, and this study is actually a multivariate study, and the study attempts to evaluate the effects of the nadir hematocrit. It doesn't actually give you the actual value of it. It just talks about the lowest hematocrit during bypass and the use of allogenic blood transfusions according to the outcome of the cardiac surgery. It's a prospective study in 3 different Italian hospitals, and it's got almost 1,800 CABG patients. What's nice is they all had this similar method of perfusing, so there's very few aberrant practice patterns. So it's a nice study, and it showed that the nadir hematocrit of bypass is an independent risk for the low output syndrome and renal failure. So that again, I was finding that this hemodilution may not cause this major failure renally. So it showed that after blood transfusions were included in this study, low output syndrome is associated with the transfusions, and the nadir hematocrit on CPB loses the statistical differences. So again, showing that transfusions are bad. It's just as bad as hemodilution. So again, Joe talked about the risk reward in this. And after blood transfusions are included in the analysis, renal failure is significantly associated with the transfusions. So that was, again, we talk about the tissue perfusion to the renal system. Are we giving this oxygen, this hemoglobin to the actual delivery to the renal system? And within the group, the hematocrits were less than 23%. It does show some value. Transfusions double the risk of renal failure. And analysis showed that similar hematocrit cutoff values for low output syndrome and renal failure. Mortality did not correlate with the nadir hematocrit as well. So, very interesting. To conclude, and in their conclusions, the nadir hematocrit on CPB played a role in affecting the outcome after CAB. The findings showed that severe anemia on CPB is a likely determinant of low output syndrome and a definite risk factor for post-operative renal failure. In addition, the role of transfusions has been established for acute renal failure because the nadir hematocrit on CPB is one of the major determinants of allogenic blood transfusions. So again, the 20% hematocrit, we're getting this blood, and now we're showing this same type of outcome of hemodilution. So we're almost chasing our tails at this point, is what this study is showing. And the role should be considered in trigger, and with this role, it should be considered in the idea of trying to transfuse. So let's talk about, the three evils of the red cells. The transfusion, the anemia, or both.
I like that.
Yeah, I mean it is the fight between. I know there was an actual study that was titled transfusion, the relationship between God and the devil. Mm-hmm. So I didn't include that one, but you find a lot of these. You find a lot of these studies, and
Oh, I've seen this before.
yes,
This is
everybody
really,
has
really
seen
good
this
slide.
or may have not seen this.
This is a great
This
slide.
I
is
don't think
a
I've seen
great
this,
slide.
so this is good.
So this is the age of blood. This is your packed red cells. I mean, everybody looks at your expiration dates of your packed cells. Like, hey, perfusion X, please transfuse this patient. Well, you get this packed cell and you look at it and it's not expired. It's
1 day before
one
expiration.
One
Most
day
of the
before
time, yeah.
expiration. I mean, I don't know if you've inspected old blood, but you see that there's a sludge, if you will. You see all these things, but under an electron microscope, it shows you these pictures.
One other
Day-
thing about donor blood is that as it ages, the 2,3-DPG goes
Is depleted.
It's depleted. It's
And so
depleted.
those cells don't actually start to carry oxygen or
Correct.
CO2 until I think it's 24 hours. I don't remember the number, but it's
It's a while.
It's a while.
On,
It's a
on
while.
your presentation. Okay,
Yeah,
so
it's in the presentation, but
Okay.
yeah, actually, no, that's an excellent point. I mean, we see these pseudopodia even at day 21. And what is that causing? Is that causing coagulation? Is that causing, the body to create like a platelet aggregation system? Is it starting the coagulation system? And a patient who is already compromised with coronary artery disease, you're throwing this in, And
Don't forget to change
oh
this.
yes, thank you. So, Patrick talked about the depletion of 2,3-DPG, shifting that dissociation curve, to the left and reducing the oxygen delivery.
You
So-
become an oxygen
yeah,
sink.
Exactly. So did we really help that patient with that packed red cell for the first intended use of that red cell? You see all this. I just talked about the microparticles in this that come off. It's not always a great product to give, but a necessary product to give.
At times.
At times.
And I think that we don't know what those at times are.
Right.
And then, of course, where are we in the development of, well, you may be talking about it in your talk, where are we in the development of a non-heme oxygen-carrying substitute?
Right.
There's some incredible work that's being done by Dr. Simpkins up in Shreveport at LSU. And he's developing a solution that is not only oxygen carrying capable and delivering capable, but also it is absorbing of and clearing of inflammatory mediators simultaneously. So he's got this incredible fluid, and I can't remember the name of his company. I'm going to have to add that maybe to the video post because he's doing some incredible work. Came to New Orleans and gave a talk on that topic, and it was really, really interesting.
Well, I would like to prime the pump with that.
Yes, well,
Wouldn't you
I think
think?
that's
I mean,
Yeah,
if
and-
we're talking
Yes.
about hemodilution,
right.
I would like to have something
I'm
like
sure
that.
it's going to be incredibly expensive.
I'm
but,
sure.
But nevertheless, I think that I'll get that information and I'll add it to the end of this presentation when Roger does the final
post-production.
editing and add that on there because it's really fascinating work that he's doing.
Baxter had something that they were working on for a while as well, but they were going to market it to trauma
Right.
To put
and
it
this
in
is a
ambulance.
trauma surgeon, by the way.
Oh,
who's
really?
Dr.
Right.
Simpkins is a trauma surgeon in Shreveport.
Well, it's medical practical values. I
Absolutely.
love the pride in the pump with that. And we talk about the decrease in the deformability and impeding like the microvascular flow within the lungs, within
Well,
the whole
that
system.
picture that you showed, they've taken red blood cells and actually
Yeah.
put them, the age cells in an accelerometer.
Yeah.
And the red blood cells, to get through the capillary system, have to deform.
Sure.
Right.
But they don't. At some
Deform,
point, they stop
right.
deforming.
Sure,
Yes.
yeah.
And so you get
aggregation.
essentially plugging of
Yes.
your microcapillary system.
Yeah.
Yeah.
And that's of course not good for you either. So I mean, blood transfusions, I mean, just are
Right.
horrible, a necessary evil.
Unnecessary evil, absolutely. And we talk about our transfusion-related lung injury. I mean, we can talk to our anesthesiologists and surgeons about trolley and taco. Those transfusion-related.
I love tacos.
Yes, I do too. And you get exposure to your bloodborne pathogens. Your hepatitis, your HIVs. I mean, we have since gotten the blood banks have since gotten better. Screening for things, but we can't catch everything. We can't catch everything, and also the blood products are starting to deplete. I mean, not as many people are donating anymore, which is quite interesting. So if we can reduce the blood usage, that would help all around. I mean, there's very many times these last couple of weeks where, hey, we're gonna need blood, or hey, we're gonna need platelets, but we're out. We're gonna have to go down on the Gulf Coast, and we're up here in North Houston, and that's coming from like an hour and a half away.
If you go to the med center, go to any of the blood, pass by the pathology lab, the blood bank areas, they have a thing
cryo
up of
pool.
all of the different
Yeah.
types of blood and
Right.
platelets and all of that kind of thing. And you just look it tells what their levels are, and it's critical.
Yeah.
I mean, it's always critical.
Yeah.
So I mean, I don't think there's any question. Blood is at a shortage and a premium right now.
Yeah.
And good donors, people who you want donating, are at a premium
Yes,
as well.
as well. I mean, so don't go get your tattoos, you millennials.
Yeah, I know those millennials.
Those
That's
millennials,
we
those
just had that
millennials with their
discussion.
tattoos, and they can't donate.
And they can't start a case till 10:45.
Correct. Well, I don't mind that. I don't mind that either. So, again, starting with this talk, what is how low can we go? This, I don't know if you can all see this, STS, the Society for Thoracic Surgeons, in which a lot of our surgeons use their guidelines. And it shows that 6 grams per deciliter is the safe operating value for CPB, which, again, to me can be very thank you, Joe, could be very unsettling. A crit of 18, what are we going to do here? So it shows that it's okay. So indications for the transfusion of red cells in this setting are multifactorial. So again, in the guidelines, it does give this disclaimer, if you will, at the 6 deciliters per ml. It's multifactorial. It should be guided by patient-related factors. It's like age, the severity of the illness, the cardiac function, or the risk of critical end organ ischemia. The actual clinical setting. I mean, are we actively bleeding? Things like that. And the laboratory, which is quite interesting. Are we using co-oximetry? How are we getting this 6 deciliters
Oh yeah,
per
what
ml?
are we using to measure? Exactly.
What are we using
and
to
that's
measure?
my talk. That's my next
yes,
talk.
I won't. I do have some stuff.
Well, you
I
go
did
ahead.
look. Yeah, no,
'Cause I can
I'm
reinforce
not.
it.
Yeah, no, absolutely. I'll reinforce you. It's your talk. So what are we trying to accomplish? What are we trying to accomplish for our heart patients? And I mean, again, I was talking about from pre-op all the way to discharge. Next, Joe. When we're talking about optimizing the hemoglobin, am I going over?
Yeah, just
Oh,
a
okay.
little, but that's okay.
I apologize.
You're fine.
So I'll try to go quickly. We're talking about the team approach. We're talking about like talking to the anesthesiologist. We're talking to pre-op. Have we gotten erythropoietin? You know, are we treating these patients like Jehovah's Witness patients? Are we increasing their iron capacity so, you know, our tissue oxygenation and delivery system is at its optimal level? You can go next, Joe. We can employ restrictive transfusion protocols in that pre, intra, and post-operative situation. The recognition of the multivariate factors such as age, sex, renal status, procedure type, and post-op blood loss. In the study and going through all the papers, I found that sex was a very important factor. Women tolerated the anemia better than men did. And that was quite interesting because women tend to have the lower BSAs than men.
Yeah.
So, and they can see that hemodilution because also the theory was because of their menses and losing or shedding that blood, their body is preconditioned to a type of hemodilution. So that was quite interesting.
That is interesting.
That was very, very interesting. And talking about perfusion technique, retrograde autologous priming. That is actually
let's talk about that.
Yes. So that again is in the guidelines within STS.
They are. It is.
It is. So again, I feel it's safe practice, and so does STS, according to miniature circuits. People stopped talking about those for a little bit. We used to run them back home in Detroit, and with great success. People would come in with crits of 30 and leaving with crits of 31 out of the room. So that was quite, I mean, you're basically sneaking on bypass with that patient's volume. I mean, there's very little. I mean, I think there was a priming volume of maybe 300 or maybe even 200 with RAP. And that only includes the crystalloid from the cardioplegia circuit. The use of integrated filters or smaller oxygenators. Terumo has a prescriptive oxygenation protocol with a certain kilo weight and BSA. I know that one of our Memorial Hermans believes in the prescriptive oxygenation. Hemocompatible tubing. The coatings that in which we run our perfusion circuits. What its goal is to improve your platelet preservation, reduces your activation of coag factors, and reduces the inflammatory reactions. That is, you know, your X coatings, I forget what is the physio, the smart coating, the physio coating. The use of hemoconcentrators and cell salvaging devices. And let's talk about, again, we talked about erythropoietin, your antifibrinolytics, your amicars, your tranexamic acids, you know, that's gonna your fibrinolytics, you know, stop you from DIC. DDA-VP with your von Willebrand's factor, and factor 7 in your factor 7, you're initiating your coags. Yeah, Joe.
Oh.
Yeah. So not only are we talking about red cell transfusion, I'm also talking about your platelets, your plasmas. If we actually take care and optimize, you know, our blood management and your fluid management, I feel that you won't need these different types of blood products. You know, the FFPs and your plasmas and your platelets also bring down your hemoglobin. So if I can reduce all those different types of blood products, your hemoglobin just stays that much higher.
I think those are great points, all great points, and thank you very much. That was very informative. You didn't even mention, though, I have to say, the cost.
Oh, absolutely. I mean, obviously,
We didn't even talk about cost.
Yeah, I could have talked about cost. You know, the price of the procurement of a red cell, the procurement of, you know, the cryoprecipitate and things like that. It's an expensive process. I mean,
Well,
doctors,
I have something to say about cost. It's not so the cost around the country is about, they say, about $600 to $700 per unit.
per unit.
that's the raw cost.
The raw
That's the raw
cost.
cost, but the cost to the hospital is a lot more because
yes.
there's a known increased risk of having a fever, you know,
Yeah,
post
transfusion
transfusion
related.
Yeah, the real cost
morbidity.
is
Yes.
around $2,000 a unit.
Yes.
Right.
Yes, and that's out of Dr. Hannon's book. Dr. Hannon has a book.
I've been trying to remember that name for the longest
Yeah,
time.
Tim Hannon.
Tim-
And, he has that book.
Yes.
And he talks about the cost of transfusions, but then he talks about the real cost of transfusions.
Right.
And they're really quite high comparison to just the raw cost. The real cost is anywhere between, it depends on what you look at, but it's between $1,800 and up to $2,800 per, because of what you just said. There are patients who are going to have a transfusion-related
Reaction,
morbidity, and they can be quite expensive. They can have transfusion-related acute lung injury. They can go into ARDS secondary to it. They can have transfusion-associated circulatory overload and go into heart failure. They can have a transfusion reaction. They can have all kinds of things occur which are very expensive, and extrapolated out or averaged out over all transfusions, it is very expensive. Not to mention, I mean, not that we want to go back to transfusions again, but not to mention the blood supply is limited.
Yes.
It's not only limited, but it's actually getting less, and the need for blood seems to be going up. So it's a big problem. It's a huge problem, but clearly, physiologically, transfusions are not good things.
Right. It showed, all these studies showed it's actually worse for the patient to get transfused.
In some circumstances.
In some circumstances. I mean, actually in most of my studies, I found that it's more deleterious. Again, it's a risk-reward benefit.
Yes.
And I found that, you know, red cells were just that much worse.
There's an argument for hemodilution if you're going to be using
Right.
hypothermia
Right.
to a point.
Right. Absolutely. You know, your lowered blood viscosity at that point. Yes.
Mm-hmm.
I did have that slide, but I took it out.
Okay, so that was very good. I'm going to go right into, if it's okay, my talk on POC devices and reliability, because I think this plays into your discussion as well. So, what happened there?
You went
What'd I do?
too forward.
Oh, I'm sorry. Forgive me. Okay, so does anybody know what clinical laboratory improvement amendments is? So we've all heard it before, but I'll bet
CLIA.
no one's CLIA. It's
CLIA.
CLIA. That's what it is. And it was established in 1988 as an experiment in POC testing. So POC, of course, as we know, is performed on many, many different types of tests. It's done in doctors' offices, in homes. A glucometer is a POC device. A hemoglobin A1C is a POC device. You can do basic electrolytes. You can do hematology. You can do even in the emergency department, a troponin level if you think a patient has come in that's had an MI as confirmation of that. So, and of course it's done in the hospitals as well. I want to give you all some perspective on the POC or point of care industry. In 2001, it was a $4.9 billion industry. That's a ton of money, okay? So I want you to keep that in mind. POC is a huge industry, very powerful industry. But of course, our concern, we are predominantly perfusionists, and I think predominantly perfusionists online as well. But you know, in the CVOR, we use it for blood gases, electrolytes, metabolites, and of course, hemoglobin. And that's really what my focus is on, the hemoglobin portion of this. There are three key elements that you have to consider when evaluating point-of-care testing laboratory devices. One, does it shorten time to result? Well, I mean, I think we all agree that most of them do. We have to send it to the lab.
Right.
The old days of sending it to the lab, and the person who would take it to the lab would first stop off at the cafeteria for a little lunch before bringing the sample to the laboratory, or the laboratory didn't know it got dropped off, and we're all sitting there waiting. Where's our result? Where's our result? Where's our result? It drives you absolutely bonkers, especially when you think you have a bad result that you really want to know how bad it is, or is it really bad?
Yeah, 25-minute turnaround time.
It's horrible. Is the device reliable? Can you depend upon it? And I don't mean that in terms of what the third thing is, which is accuracy, but is it reliable? When you turn it on, or when you are ready to do a test, is it available and functioning? That's what I refer to when I talk about reliability in this particular talk. And are the results accurate? That's very important. Are they accurate? Can you rely on the results that you are receiving? So I want to show you some of the more popular POC devices. Each of these devices has advantages. Each of these devices have disadvantages, and it becomes a matter of, do we even know all of these devices actually exist, or do we only think it's the one that we currently use? If you've only been one place for any length of time, you may not even realize how many different devices there actually are on the market. And I don't know if this isn't all of them. These are the more popular ones that I'm familiar with. So on the left, of course, we see the Abbott iStat, which was really first on the market when it came to POC technology. And they developed this device. I can't remember the year, but it's been quite some time. And they've been extremely good at marketing their device and so forth. And it has some advantages. We're going to talk about those advantages and disadvantages. But then next to it, you have the Siemens technology. This is the Siemens Rapid Point 500, which is a device I particularly like. You have next to it the radiometer device, which is also a very good, this is the ABL or radiometer device, and I think this is the, I can't tell you what model that is, I don't remember the model numbers.
The ABL 80.
It's that's the
80 coax.
And that's then next to it is the GEM 3500. I think they have the GEM Premier. This might be after the GEM 30 Premier. I don't really know.
Right.
But nevertheless, each of these devices have advantages and disadvantages. I want to point a couple of these out while we're sitting here right now. So if you look at these devices, the obvious advantage, let's see, is it going to work?
Yep.
Yeah.
Yeah.
The obvious advantage is in this model, it is literally handheld. You can carry this thing around with you from anywhere to anywhere and do whatever it is that you want to do, as long as you carry the cartridges with you. This device has is a tabletop platform. It can be on a cart. It can move around the hospital very easily. And it has its own backup battery supply and the whole thing like that. It is not a gigantic desktop model like you see in the blood gas labs, down in the laboratory or the pathology department, but it is. It certainly isn't handheld. It's luggable. It's not really or pushable on a cart. But some of the advantages that this has is that it has a Loor lock input right here, which makes it almost mindless. You just connect it, hit the button, and you can leave it, and it will draw the sample. The other thing it has, of course, is up here, you have a printer readily available. In this model over here, the Abbott iStat, you have to, I guess, laser connect it to a printer, dock it to a printer, and then it's a separate device. So if you did want a printer then you would have to carry that printer with you along with this handheld device. The ABL machine over here also has a port, but its port comes out and it's a needle, and you have to insert the needle into the syringe sample, and you have to hold it there until it draws the sample up. So in that regard, I think this device with that Loralock technology is very helpful. It also has a printer though, and it is certainly a solid device. And then you have the GEM over here. It also has, if you can look right there, that needle comes out to aspirate the syringe, the sample from the syringe, so you have to stand there during that period of time. But it also has a printer. Now these three are all in the same class. They're all luggable devices, mostly meant to be on a cart to move around or put in the heart room. This one is clearly the one that has the handheld, which is the easiest of all to just walk around with or transport or move. But there's some other things that I'll bet most people don't really think about, and that has to do with liquid QCs. In the case of this device and this model of this device, the QCs, the electronic QCs, are not electronic, but they're all liquid QCs from the cartridge, are actually done through the measurement pathway. And because they are done through the measurement pathway, you do not have to do liquid QCs on these devices. You can, but you don't have to, because the QCs, which are liquid in the cartridges, which are behind these doors, are actually measured through the measurement pathway. In the case of the GEM technology, it is not. It is a separate pathway. Therefore, this device always has to have liquid QCs, as does this device when you have either, depending on your hospital, a new patient, or you have a new lot number. It could be any of or both of those.
Yeah.
So, and it is quite time consuming and, in my opinion, quite onerous, and something that I really dislike about those two technologies. In regards to, what I do wrong?
Also hours.
Oh, I'm
Depends on
sorry, I
hours.
think
We
I
have
went-
we have a hospital that only allows us to use it if
8 hours.
8 hours.
That's right, and you have to
Within
do
it.
liquid QCs all over again.
Yes.
So in the previous slide, I sort of showed you the nuances of these three devices, but I want to take some time, so I'm not going to go over it again, but I'm going to show you an example video of how this port really helps. This device, of course, has the needle. This device has the needle. These two devices have the QCs through the measurement pathway, or the same sensors,
Right.
which eliminates the need for liquid QC technology. But talking about reliability, you now have what you see here, which is frequently the case. This device, this iStat device, you will frequently find having to be put under warm blankets in the operating room,
Yeah.
Right.
because it will not work in colder temperatures where we like to keep our operating room at. And there are many, many, many times where I will come to the hospital, come to work, and be having a seizure, essentially, because I cannot get the thing to turn on because it's too cold and they're ready to do a lab. So
I'm
when
glad
you
you're
go
not the
to-
only one.
Yeah, when you go to this hospital, exactly. You don't want to go to this hospital that I'm talking about late for a procedure or
Correct.
for an emergency, because
Correct.
this is what you have to contend with.
And
you-
I'll say what I've tried is you put it in the blanket warmer, and then it just totally freaks out.
and then it's
because
too hot.
Yeah.
Right.
too hot.
Right.
So there's
it's too
almost-
hot.
There's just no hope, okay?
It's- yeah.
And it's really problematic. Not to mention, and I'm going to show this in the video as well. Look, I'm going to make a statement here, which may be a little bit controversial, and I'll be a little controversial. I tend to not hesitate to be so. I think that as a first generation device, it was a very good device, and it worked really well. But one of the big problems with it, and let me move on to my well, first let me show you this, is The Siemens device, the rapid point that I talked about, there's some researchers who needed to do laboratory, point of care laboratory at Base Camp Mount Everest.
Wow.
The only device that they could find that could operate in those temperatures happened to be this Siemens Rapid Point device. So when you are in a cold operating room, I will tell you what, that is not problematic with this device. It will actually continue to work. But I want to talk about something that is, in my opinion, much more concerning. And that has to do with the accuracy and reliability of the iStat point of care device for the determination of hemoglobin concentration before and after major blood loss or before dilution. Okay, this is the thing that I think is the most important. And kind of going backwards, without going backwards through the slides, the other three devices that I showed you, the Siemens Rapid Point 500, the ABL technology, and the GEM technology, use co-oximetry for their hemoglobin measurement. And co-oximetry for hemoglobin measurement is a gold standard. And that is considered to be reliable to laboratory standards. In the case of the iStat, it uses that's photonic and what is the word I'm looking for? I can't think of it. I just blanked out on the name.
It's an estimate.
This is this is done through a resistance, and forgive me, I've just sort of lost my train of thought. It'll come to me later, I'm sure. But looking at this study, let's focus on the part in the red. Clinicians should not use the iStat hemoglobin in isolation for clinical decision making when considering blood transfusion in a situation of 25% or greater blood loss. Well, when we go on bypass, we are diluting the patient a minimum of 25%.
That's it, yes.
Okay, I don't think there's any question about that. In addition, this study, which of course, we're not doing neonatal pigs, but I think the point is there, okay? And this is veterinary medicine. But it says the lower the protein values were, the lower the hemoglobin values were measured by the iStat. The conductivity, that's it. It's a conductivity method, and the other, of course, is co-oximetry photo. I can't think of the word, doggone it. Never mind. Whatever. But measured by the iStat, the conductivity based measurement of hemoglobin constantly underestimated hemoglobin values, whereas the photometric, there, it gave it to me finally, method demonstrated a better accuracy and is therefore more reliable measurement of on-site hemoglobin, of course, in this study in pigs. And here is another study done, and it shows, let's just, you can read it if you like, but essentially the manufacturer, which is Abbott themselves, the company that manufactures the device, recommends using its own POC device to make transfusion decisions. So somebody help me understand, why are we doing that still?
Yeah.
Anybody that wants to call in fact, let's just open the phone lines now. Call in and explain to me how it is possible in 2018 that we are still depending on a device to make transfusion decisions when the manufacturer itself says not to do that.
Not to do.
Because of its lack of reliability.
Right.
So, the real question, we'll get to this, but, oops, sorry. So from our results, the iStat analyzer is suitable for point-of-care testing, and it works great for electrolytes. It works great for blood gases. I mean, I think there's no question in my mind that the device is not a bad device. the device is not a good device for hemoglobin measurement. So I don't want to,
It's
make
limited.
it sound like
Yeah,
it
it's
has
limited.
right.
It has its
And I
limits.
think that, if, you've got to make a decision. We have only so much money. You've got to buy a device for your operating room that you're going to be doing point of care testing with. Are you going to get two because this works really well for the blood gases and stuff, and have that either, it doesn't matter, the Siemens, the ABL, or the GEM as your, just for hemoglobin? Or are you going to use a different hemoglobin technology, or are you going to get just one machine that's going to do everything that you need seamlessly? I think you're going to be really impressed with these videos. I really do. But nevertheless, this shows basically the same exact thing. It's really good very accurate for blood gases. It's very accurate for electrolytes. It is not good for hemoglobin hematocrit. So basically, this text came across from this mother: your great aunt just passed away, LOL. Why is that funny? Says apparently either the daughter or the son, and a son, obviously. It's not funny, David. What do you mean? Mom, LOL means laughing out loud. Well, oh my goodness, I sent that to everyone. I thought it means lots of love. I have to call everyone back. Oh God. So, it's how you interpret your results. What does that number really mean? But don't worry, because we have an algorithm for this, okay? And the algorithm is a thing you select on the iStat device that says, are you on pump or are you off pump? Well, should it say, are you hemodiluted or not hemodiluted
Right.
instead?
Yeah.
Correct.
I mean, so when we come off bypass and we're using this device, this iStat device, and we have to select it, we're off pump. We just came off bypass, we're off pump. What do you put?
I select that we are on pump.
You select your on pump. So you're, okay, but can that become a medical legal problem?
Yes, absolutely.
It's a good question. I'm going off of the basis that we're still hemodiluted, and I understand on pump off pump doesn't really mean on pump.
You're going to have to explain that to a jury, Patrick.
I know. I'm getting ready.
You're going to have to.
And the
What do
bottom
you
line is,
think?
I want to give a good number. I feel like
Right.
that number is a better number because it's skewed in my favor.
Right.
Yes, that's true. That's
And I wouldn't say
true.
that to the jury,
But
but I would say it on the internet.
You want that? So what do you think?
No, absolutely. It's gonna cause an issue. Obviously, it's really not an issue of the actual physical being on bypass or off bypass. It's about hemodilution.
Yeah.
It really is. I mean, that shouldn't really be the verbiage. Yes, but I do choose on pump because we are still hemodiluted to get the correct or close to correct values that it
But is
intends.
it? I mean, do you really trust an algorithm?
No, I don't.
To take a
Personally, I
number
don't.
that using the conductivity method. I can remember
Correct.
the word now.
Yeah.
Using that method for measurement, and then plugging in some algorithm to it to make it give you a different number. Do you really trust that? Do
No,
you trust
I don't.
that?
'Cause
I haven't trusted the iStat for a while, to be honest with you.
I believe in coaximetry. I believe in coaximetry only because.
And I think a lot of our perfusion colleagues don't realize this. I think a lot of our perfusion colleagues really don't understand. And I think part of that is the fault of all the other manufacturers. I don't think they really call on us very much.
Right.
I don't think they really consider how much influence perfusion has
Right.
in the selection of the point of care device that we're going to use in the CVOR.
Because we're such a small population. I mean, an iStat is maybe chosen for the OR because we are not the only users. And one of our hospitals, any nurse can walk in who's trained, can use the iStat. And whereas if we had a benchtop, not a benchtop, but a luggable device, as you call it, we have to be trained. We have been trained. I've used one for as long as I've been a perfusionist. Yeah, I mean that is a more reliable device. And
I would
you know,
almost rather just
oximetry.
send the lab to send it to
Yeah,
the lab.
absolutely.
Well, frank with
It's
you
to be-
anymore today,
exactly.
I would rather send it to the lab. But let me.
I have a story that I think is pretty pertinent here.
Please.
And I'm going to leave all the names out because it's that kind of a story. There was a hospital that we were working at, and the surgeon worked at several hospitals and was wondering why we were giving so much more blood at this one hospital. And, you know, patient population was similar and all that. And the iStat at that particular hospital wasn't programmed to have the option to say on cardiopulmonary bypass or
Right.
off. And so it was always assuming that we were off cardiopulmonary bypass. So we were getting essentially, we could say that they were false lows,
false lows.
and we were giving more blood because of it.
Yeah.
It was so simple.
So let's think about this
once
for a
they
minute.
reprogrammed that, we gave less blood.
Right. But let's think about this for a minute.
That's something to
Again,
think about.
you have to make the decision. So if you're the nurse in the ICU,
They work off
And
trigger numbers. So
you're
yeah.
hear me out.
Yeah.
You're in the nurse in the ICU, and the patient is hemodiluted, and it's giving you a false low value, and it is within your parameter to transfuse that patient based on everything that we know about the deleterious effects of transfusions that we've been talking about. It is mind-boggling to me how many patients I personally, you guys have, many nurses have, many anesthesiologists have, many CRNAs have, transfused that didn't actually need that transfusion.
Oh,
And that really concerns me. And I think that we need, as a group, to start being more vocal about the reliability in that will it work when you need it, and the accuracy for every test that's being run. I think that either the company, Abbott, should remove hemoglobin from its cartridge and not have as an option, or we should just stop using it in lieu of something else that we feel confident in. And I think we need to become more vocal with that. So let me show you some more things that I think are very interesting. I'm going to show you a video, and it should start playing. I think it'll play automatically. I think I have it set up that way. Yes. So this is Rodell. He's not wearing gloves. He has the iStat. Okay, so there's
I'm old school. No
Stephanie,
gloves.
if you're watching, you please put that on his evaluation.
Yes.
So he had to go over there and scan everything, turn it on first. Now he's going to draw his lab. There's a lot of perfusions. I was watching you do this where you pump it back in like that. You're lysing all those cells. Now he's going to draw a sample.
I do it carefully.
He's going to put it in the device. Insert it. And now, about 2 minutes later,
2 minutes.
he will have a result. But I don't know if you watched all of the inattention or the attention that he had to give that device while he was actually doing it, as opposed to, go ahead.
Oh, I
And
mean,
you
I was
were
watching
prepared.
the pump the whole time. I was
Right.
prepared. I was watching the pump
Yes,
the whole time.
well, I know.
I'm just letting you
But
know.
let's just hypothetically say
Right.
you're doing this with two hands.
Yes. Right.
And you have
Correct.
to now make a change or do something immediately on the pump.
Yeah.
You're going to have to
Correct.
drop that sample
Yeah.
and
That's
move
correct.
on.
Absolutely.
Okay, so that's one thing. And then you of course were prepared for this, so
Yes.
you did this knowing you were going to videotape it. So this was best case scenario. Now let
Correct.
me show you another perfusionist. This is the second video he had to send me. The first one he didn't show something that I needed him to show, so he's actually off pump and pretending he's on pump. Now it's Clint Robertson. He's clearly a better perfusionist because he's wearing gloves. I think everybody can see that. But they are off pump. He doesn't run his level down there at 50 cc's. It goes in the port.
Wait, it's
hits
not
the
showing up.
button.
It's not on the.
Oh, I'm so sorry. Let me
there
try
we
it
go.
again.
Yeah.
Okay,
Oh
so
yeah, look at those gloves.
yeah, look at those gloves. Everybody see those gloves? Okay, so he draws the sample.
OSHA must have been
Now he's
there.
off pump. He puts it into the Lorlock Now, if it was the other devices, the needle would have to come out and you'd have to hold it. It's still better than the iStat clearly because it has co-oximetry, but this is the one that I really like. It comes out, he hits the button, he goes back to whatever he's doing. The sample is being run. You can see the results will populate here. It takes roughly 45 seconds from the time you introduce the sample till the time that you get your results. And it gives you a little countdown there so that you can actually see how long it's going to take. And he was off pump, so I don't know if you saw that or not, but the pH was like, was the PCO2 was non-existent. But then it printed it and he took it out. But it's a good, at least, example of how easily you can run this device versus all of the little machinations you have to go with the various cartridges. And it has that secondary benefit of doing the liquid QCs automatically. It says automatic QC right there through the measurement pathway, eliminating your need to do all of these liquid QCs. And it operates at extreme cold temperatures. I'm very supportive of the device. I think, however, whether it's this device, the ABL device, the GEM device, or other devices that may exist, I think anything with co-oximetry that has reliability and accuracy is better than using the Abbott iStat in the CVOR for hemoglobin measurement. We need an alternative to it if we're going to continue to use the iStat. We should not depend on that value ever. Okay, you have any questions or comments, call in. Let me go to the YouTube chat to see while we're waiting for that to happen and for that delay to tell them to go ahead and call in. Here we go. I have used iStats and we did lab comparisons, I think semi-annually, to verify validity of results. There is a CPB hematocrit choice, and if there is a discrepancy, you can adjust the equation. I didn't know that.
Oh.
There is also an Epical device handheld to iStat, but less expensive. Oh, EPOC, I think she means.
Yes.
And we also select CPB hematocrit for the first post sample. Great questions, Kimberly. Questions and points. And points, Kimberly. I am of the opinion that we need something accurate that does not depend on math to compensate for inaccuracy.
So my first perfusion job, which was in 1820, just kidding. My first perfusion job, I spun the crit, and I loved that.
Oh.
It was a little tube,
Right.
and you'd stick some clay in the bottom of
Yes.
it and spin it, and then you put it on a little chart. And I liked it for a lot of reasons. I knew it was very accurate, and also it was fast.
Well, spun crit,
Yeah.
basically
Right,
what you're
yeah.
talking about. Yeah.
And it took very little blood.
Yeah.
You know.
Yeah.
Just thought I'd bring that up as a.
Yeah.
I don't know if
Little
that's even
anecdote.
something that we could use these days or not. I don't know if that's. There is some judgment involved there. It's not a number that spits out that says, you're at 20%. You got to
Yeah.
estimate basically. You're probably based on your eyesight.
Yeah, no, I think
little bit off, but-
I think the better thing to do, frankly. I mean, yes, you could, of course, put a centrifuge in there and spin a crit in the OR if you wanted to. I think that I think rather than go back to medieval days, I think we
Right.
should advance. And I think Kimberly has some very good points. I don't know if y'all heard them. I responded to it, but she basically says she's using it and that you could do these things. Abbott can adjust the internal equation, so no math for us. That's true. Yes, I agree with you there on that, Kimberly, but it's still depending on math, whether it be Abbott's
Right.
math or whether it be our math, really doesn't make any difference. You're taking a number which is wrong because it can't read it accurately, and you're using an equation in order to compensate for that inherent inaccuracy to make it correct. And in my opinion, I think that is wrong. I think we should be able to rely. We need a gold standard in the operating room, and that's just how I feel about it.
Right.
I think that the Abbott iStat device does work very well for blood gases and for electrolytes, and I think that its functionality for that is just fine. I think on bypass, it can be a little bit cumbersome playing around with it, depending on what kind of cases that you do and how you have your system set up. But I think that at the end of the day, I want something that is reliable, something that is simple to use, something that is accurate, that my attention, it requires less and less and less of my attention to give me more and more and more accurate results back to me. I mean, what say you?
Oh, absolutely. I mean, I'm getting pressure from a particular surgeon, and he goes to all of our hospitals, so he sees the aberration with the iStats versus the bench tops that we send down. And he's asking me, like, hey, why are we using this? How come we're getting such low hemoglobins? I mean, now that we're going, hopefully we'll be STS rated, are we trying to prevent transfusions? I mean, does this patient need a transfusion according to this iStat? I don't know how to answer him. I mean, I do have an answer like, hey, you know what, this is usually 2 grams difference between a bench top.
I know how to answer them. I'm going to give you the telephone number of somebody to call tomorrow
Right.
to solve this problem, because I think the problem could be
But
solved immediately.
I agree, but you know, I don't have that power. Like, I am a big proponent of co-oximetry and this device, or a device that uses co-oximetry. Mm-hmm. It breaks down your hemoglobin saturations, and to the point where it shows you your methemoglobin, and it shows you that carboxyhemoglobin, and this shows you how much oxygen is actually getting delivered, or how much content of oxygen is getting delivered to the tissues. I mean, that's how sensitive it is versus this little cartridge of iStat. I mean, it seems like I'm beating up on iStat, but
well, I've been doing it for the past 30 minutes.
Clearly. But, I just don't. I wish I had an answer for this surgeon. I mean, I do have an answer for him, but can we accomplish getting a co-oximeter machine?
Yeah, and it would have to be brought down to really a cost thing. And so
Right.
the argument would be, again, what does it cost for a blood transfusion, which we talked about,
Right.
and what does it cost for this new machine
Right.
and the maintenance?
Well, what
of
does it cost for this machine versus the other machine?
Right.
If it's cheaper,
Yeah.
more reliable, and more accurate,
Yeah.
and simpler to use, I mean, where's the disconnect?
I don't know is iStat cheaper than some of the other options?
No, I think it's the other way around.
Okay, it's more expensive.
But again, I'm not a look. I don't.
Yeah,
I'm not a
yeah.
salesman for these other companies,
Right.
nor am I a salesman against somebody. So I have to. I mean, I've been pretty direct with how I feel about it.
Right.
But I think that they need to explore. I've given the information right here.
Yeah,
You
absolutely.
have these companies. These
Yeah.
are the advantages.
Yeah.
If it were me, what I would want to use, I really like the Siemens Rapid Point machine. I think it's a great technology. I've used it many different times. I've used it down in Mexico, and it works very, very, very nicely. I do have experience with the GEM as well, but I don't like it because its QCs are not done through the measurement pathway, and you have to do those liquid QCs. And look, I mean, I just want to be able to walk into the operating room at 1 o'clock in the morning and be able to set the pump up, prime it, go on bypass, draw a sample, stick it in the machine, and hit the button, and know that it's going to be
Yeah, no
on and
question.
running and working.
Yeah.
That's
No
what I
question.
want, and be able to
Right.
truly believe every result is being measured. As I said, I don't think the iStat machine should be thrown off the market and never used by anybody, because I do think that it has good utility for other things. But it should not measure the hemoglobin if it cannot deliver a hemoglobin value that one can trust and rely upon without having to make a decision as to whether to choose on CPB or off CPB when you are clearly not on CPB, but the patient's condition is similar to that it would be if it was on CPB. So I'm going to pick that even though I'm nowhere near even the operating room. I think that is, and
Right, it's a judgment call.
And just using an algorithm to correct an inaccurate value, to me, is not appropriate, and I don't think it should be allowed. I think I think it needs to be stopped. That's what I think.
You know, something we didn't even talk about is there are places using VIA. I think it's called a VIA inline.
Oh my God, yes.
Yes,
what
and
you're
I know
talking
that's
about.
not accurate at all.
No,
And,
that's
terrible. But
Yeah.
they do that.
No, they do, but yes, but I don't know that they're relying on that for I don't know what they're relying on that for. I mean, do we use that in any of our programs?
There's a hospital.
There is a
I'm
hospital.
not going to say a name. But
Yeah, don't say its
There is a
name.
hospital, yes.
Where we work.
Yes.
Okay.
It's terrible, but it's true. It's
Yeah,
what they have.
it's
and
what they
sometimes
have,
it
it's
doesn't
what they
work at
have.
all.
Correct. Yeah, I mean, if they don't have, like we ran into an issue where they did not have the correct QCs, so we did not have a value system for a couple weeks. So
Yeah,
we
I
would have
remember
to
that.
send the lab down.
And that took 20 minutes at
Yes,
least.
absolutely. Yeah.
minimum.
Again, it's the turnaround time, and it's these surgeons. They're starting to get wise to it, and they're saying like, hey, I've done this bloodless surgery,
Yeah.
and we haven't lost any of this blood. Where's it going?
Yeah.
I mean, I know you're not hemodiluting. I mean, I know the CRNA and the anesthesiologist haven't given an exorbitant amount of volume. What happened here? It's like I've done all this hard work, and now they're gonna get taken down by a couple pack cells. We're gonna get this adverse outcome.
Well, I mean, should we say, giving a transfusion in that case is probably not an emergency. Should we be saying, I don't have confidence in this result. Can we please send a hemoglobin to
and
the
we
lab?
have, and
send
we
an
have.
H&H to the lab.
Yeah, we can do that.
We have, and it's come back. A couple deciliters is higher, but then
That's pretty high, 7 to 9.
Yeah, 7 to 9, absolutely. And that's probably before we've given Cell Saver. And it's going to be even higher. But again, it just makes us look like we're unreliable. We're using the incorrect instrument for what we're trying to measure.
We are, but it's not our instrument.
But it's not.
what they're giving us.
Agreed. It's what we're given. It's what we're given. But it can be a perception type thing as well.
Well, then why don't we fix it?
Yeah, I would love to
Yeah,
fix
I think
it.
what we're
I would
we're
love
talking
to
about
fix
is
it.
I think we need to be more vocal
becoming
about
a proponent of changing the equipment,
Right.
and saying
Absolutely.
this is
Right.
but being
Absolutely.
educated about why we're
But I
making that
think
decision.
how you do that is by every time you got that result, you said, I don't trust this result. It's going to start that conversation.
Right.
Or just
I mean,
ask
it
for the
has.
conversation.
Yeah.
Yeah.
And say, we need to talk about this. What we're doing is not working. Here are some options. Here are the telephone numbers to the people that you can call about some of these other options. Can we look at this and make a decision? Because I think what we're doing can be done better. And talk to the surgeon about it, anesthesia about it, the OR director about it, and let them evaluate whether or not there is a value basis for them. That if it's cheaper and it's more reliable and it works and everybody wants it, sounds like a change should be made.
Right. But it's actually it's quite a fight institutionally as well. It took a long time for us to get an iStat from a device that was probably at its optimum, in the 80s. It's now we're trying to introduce a brand new device. Sometimes it's a fight.
But they're not brand new. They've been around for a very
But
long
what
time.
I'm saying is just it's brand new to them.
to the CVOR.
to the CVOR.
Maybe. Yes.
So
Yeah, but I
there's
think
that
people are-
hospital.
So what do you think about this? Now, we do have a couple. Let me do this while we're at it. Let's see if somebody's going to call. I've asked Kimberly to call. She's doing good with the chat tool. But I want you, Kimberly, I want you to call on this phone and discuss this matter or anything else you might want to discuss. But I know that both Patrick and Rodell are on call today.
True.
And Stephanie, if you're watching, thank you very much, has been kind enough to cover Rodell's call, and she's
my
watching
call.
an ECMO at one of our hospitals as we speak. And she did
Patrick's
ask
call.
me to get you there as soon as possible because she did have a hair and nail appointment that she needed to go to. So, let's see, that's
I
not
was
bad.
kind of hoping you'd stay for my talk because
Actually,
that way you could
this,
kind of
Okay,
this
well,
actually may be
Stephanie-
a call for.
That-
Actually, I have to take this.
Okay. So he truly is on call. And while he's taking
Hello, this is
that
Rodell.
call, let me talk about next week's program. Or not next week's program, I'm sorry, our next program, which is going to be March 24th. And that program is going to be really, oh, we got a caller here. Hello, you're live on the air. Hello.
Oh, hey, I have a question for the panel.
Yeah, who we speaking to?
Oh, this is John Campbell. I work in Riverside Methodist Hospital, Columbus, Ohio.
Okay, cool, John. How nice to talk to you.
Okay, should I just pose a question then?
Sure.
Okay, so I wrote it down, but I was going to text you and I'll just read it. So regarding the hematocrit on CPB, low-risk patients without advanced age, without preoperative risk for renal failure and stroke can be safely perfused with hematocrits between 18 and 20%. I think the literature you guys put up pretty much evidently showed that. I'd like to say that if, however, one needs to transfuse, it's best to transfuse early rather than late. Furthermore, I would surmise that if you could wash or hemoconcentrate out broken fragments and elevated acidity, rates of acidity, so elevated pH prior to CPB would be better than dropping them into the pump while on CPB. So pretty much you knew you're going to have to transfuse at some point in the operation. It's better to just go ahead and prime up with blood rather than drop it in. And then I was wondering how much of the negative effect of the actual RBC unit is the fluid medium versus the actual hemoglobin itself. What do you guys' thoughts on that is?
Oh man, those are. I mean, those are great questions, John. And I wish you were here with us right now. Well, as far as the impact on it, and maybe Patrick can elaborate on Rodell can elaborate on this a little bit more. One of the things I think that everybody recognizes, and Rodell pointed it out, that you see this sludge in these older units of blood. And also, of course, they've sort of lost their morphologic shape. They're not able to distort and get pumped through the microcapillary circulation. They're depleted of their 2,3-DPG. All of that combined, I think that those are all very real reasons why it's easy to say banked blood when it's any older than maybe 2 or 3 days tops is really not good. Not to mention the potassium.
Oh,
is very,
increased
very
potassium.
high
I was just about to say.
There's tremendous numbers of lyse cells. You have
Right.
plasma-free hemoglobin in there. I mean, there's all these issues around it. But let me ask you this, John, since you brought up transfusing early, none of us talked about, and John, I'd like your thoughts on this. Washing the bank blood in the cell saver.
I was just thinking that.
Before we actually transfused it. What are your thoughts on that, John?
We do it
Well, I
for,
definitely think that would be a positive aspect if you could do it. I mean, you get in big trouble with it. The blood banks never found out unless you had some kind of protocol in the
Right.
airwalk. I think
Really?
the easier
Yes.
way to do it, yeah, for sure. The easier way to do it would be kind of like, there's a nice write-up from Gary Grist years and years ago when, pediatrics, you can't always do it like in an adult practice, but it would be like, let's say you drop 2 packed cells in your reservoir, and then you drowned it out with, say, like 5 liters of plasma and just hemoconcentrate it all down to whatever your priming volume would be prior to CPB. That way you're pulling off as much, you're diluting out all that stuff and then pulling it off before going on.
Right, and then
If you can get away with it, that's a
good
time
idea,
consuming,
I guess.
Yeah, and then depending on the filter, basically the blood filter to capture all of the stuff that you don't want going in there.
Yeah, exactly.
Yeah,
And that way you
that's-
can tailor you can draw blood gas on that, I guess, beforehand and tailor up all the numbers, what you wanted before going on. It takes a lot of time.
Yeah, that's a really good point. But let me ask you this, and y'all are going to have to educate me. What is this thing about the blood bank? You can't wash bank blood in a cell saver and then give it back to the patient. What's that all about? I never heard of this.
Yeah, me neither. We did it when we were doing pediatrics. We washed all the cells, and the blood bank had nothing to do with it.
Have you heard
From
of
what
this?
from what I understand, it has to do with oh, what was it? It was the standards in which how they collect it, and now you're altering that actual packed cell.
So
And
you've
their
encountered
their
that before,
standards.
where you
Yeah.
had to follow a protocol to wash blood in the.
Yeah, I know
Right.
that there was a specific protocol at my former hospital about that.
Right.
And then just a nice write-up on, I mean, I have to do a personnel search on it, but there was a strain years ago on that as well. I mean, personally, I think, out of sight, out of mind, and, if a tree falls before it doesn't make a noise, but, unless you find someone who's going to turn you in for it, it would be fine, but I would prefer to wash it if I could.
Yeah, I think that makes, well, I think that we didn't even discuss that. I think that would make a whole lot of sense.
Oh, it makes a
as far
whole
as
lot
that
of
goes.
sense.
Yeah,
but
So,
I
John,
believe
let me ask you, what's your transfusion trigger up there? I mean, do you have a specific number that you're using? Is it case dependent? Are you doing RAP? Are you doing ultrafiltration? What's your practice like?
Oh, John's not a
Well,
rapper. John
we
is
do
not a
about
big proponent.
1,200 cases a year. I don't know how many are like cabbage and so forth, but we have one guy that raps. I don't rap. Just one of the surgeons that rap. They're super fast. We have, I hate to say it, but we do have like a transfusion trigger per se. It's like probably like 7.1. You have to pretty much come off bypass at a hematocrit of 7.1 or higher. It's like part of our TQI or whatever. You get flagged pretty hard for it if you're below it, actually. But so, and then they check it again in the unit upstairs right after we arrive, and I think it has to be, at that stage, it has to be 7.5 or higher. Otherwise, they'll transfuse upstairs. And unfortunately, it's not all factored in. I mean, I would say, like, if you were a low-risk cabbage patient, you could probably go as low as 18. And then if you had diabetes, say we just maybe up that number to, say, 20. And then if your age is, like, 70 or 80 plus, and you probably add a couple more in. And then if you're, carotid stenosis or something, perhaps, even more. And now you're looking at probably lowest, say, hematocrit, anywhere from like 22 and up, you know what I mean? That's what I would think. It just kind of stands to reason, I don't have the empirical evidence to support it, but that's just kind of what I think.
Well, I do, and I think that a lot of the studies that are out there, I think that there's so much data out there, and a lot of it is very conflicting. I mean, I know I had of course, we do the conference in New Orleans every year, and one of the surgeons that came out, his name was Dr. Mark Gerdish. He's from, where's he from? He's from somewhere back east. I can't think of where he's from, but a big-time valve guy. And he was talking about hematocrits of 16, and we're not transfusing the patient at 16.
Yeah.
So they are really, really pushing the
restrictive.
envelope. But my argument back to him was, what's the what are you talking about? A patient who has a depressed ejection fraction, is very sick.
Yeah.
Is it not just really about DO2? If you have a normal patient and you're delivering enough oxygen at a hematocrit of 16, I would say you're probably okay.
Right.
If you have a really sick grandmom who has a really bad vasculopath, has a really bad heart, and had just had valve replacement, and heart's not beating all that well, I mean, a hematocrit of 16 is probably not going to do it for her in terms of just being able to perfuse her tissues. And I think that, kind of going full circle with all of this, you could, even TCD wouldn't help this, but how do we normally don't measure DO2 in the operating room, and we sort of look at our flow and we look at our gases.
We look
and
at
you can
SVO2.
use surrogates, right?
Yeah.
You can, if you're not developing acid, you're probably okay.
Right.
But it's not real time. I don't know if anybody has any experience with the LIDCO device or the Vigileo device. I like the LIDCO because you can calibrate it, but that actually gives you continuous cardiac output non-invasively off of the arterial waveform. But it also, you plug in the hemoglobin, it gives you real time continuous continuous O2 delivery. So if it's about DO2, you can reach that threshold, and if you see it going under that, then take appropriate measures, whatever they may be. Something else to add to our transfusion algorithm.
Yeah, you know,
Yeah, I think another point I'd like to make is that in a practice like where I work, we could probably push them a little more so than others, in the sense that our procedures are really, really fast. So I think surgeons are all pretty well skilled, and CPB times for like capture times 4 probably under an hour. You know, like so. But you can go to a lot of places, you know, especially these small hospitals that don't do a lot of surgery, might not have the best surgeons. And then you're looking at a CPB time of like say 3.5 hours, you know, and that's a lot more time to be after say 16 than if, you know, my guy who I'm rewinding from 34 to 36 for maybe like 15 minutes, you know what I mean? Where your oxygen consumption might be higher, you know.
Yeah.
So
we have
that's something that never shows up in, you know, the literature, really, you know.
Right, exactly. And another thing that doesn't show up in the literature, I think, Patrick, you're trying to say something.
Well, there's two things.
Yeah.
Just not to get too off topic, but John, what kind of point-of-care device are you using?
Yeah, the iStat, yeah.
iStat, okay.
Really?
All right. Right, okay.
Okay.
So,
That's totally out of my
but
hands.
about
Yeah,
O2,
no kidding.
about DO2, I'm not plugging any company, but LivaNova, their electronic charting
Yes.
system actually can track that. And there are perfusionists out there who are, they're not even looking at their flow, they're looking at DO2.
Right.
Because the machine will convert that for them, and so they'll change their flows and
interesting.
change their practice.
But it has
based
to
on
have an
DO2.
accurate hemoglobin.
That's true.
Right.
Yeah.
So that number will be reflective of whatever number you tell it is.
Right.
So, John, you're going to switch to another device instead of the iStat?
Yeah.
Oh, I have no idea. That's the way I run my trade rate, though.
Can O'Shaughnessy take care of that, or maybe Mr. Cruz can?
Do you know John?
I do know John.
Oh, you know
I
Rodell?
recognize. Yeah, I recognize his voice. I'm like, wait a minute. Okay, I do know this guy. A good friend of mine. Very good friend of mine.
Well, John, how's Rodell doing?
It's been pretty good, man. Doing really good. I'm liking the talk so far. So.
Thanks, John.
That's fantastic. Well, listen, John, thank you very much. Great thoughts, great questions, great comments. Very provocative, and I think very thought-provoking for all of us. I think we're going to have to go to a break here real quick. So, but listen to the next segment. You might have some thoughts on that too. Please feel free to call in. We'd love to hear from you.
All right. Thanks, man. Appreciate it.
Man.
Hope you guys are having a good day.
All right,
Thank you,
cheers.
sir. And so
Bye.
next week, not next week, I keep saying next week, on the 24th, the Saturday the 24th, we're going to have a really different kind of session. We're going to have Dr. Michael Duvall, that's M-I-C-A-L. She is very attractive, not a male Michael. And she's going to be talking about basic TEE for the perfusionist, something that we all see in the operating room all the time. You know, we've got TE going on, and do we really all understand this very well? I mean, I kind of do, but do we really understand it and all the different views? I think this will be good for a lot. Maybe our younger colleagues don't. We're older, so I think we've seen it so much. I think we're a little better.
I can look at it and I can say that's not so good, but I can't tell you what the details are.
And then to follow him will be, or to follow her will be her wonderful husband, Dr. Lucas Duvall, who is going to talk about how to read CT scans for the perfusionist. So when they bring the patient in, I've seen this, I don't know how many of you, but they start going through the CT and they're just wheeling down and the neck is coming in, the top of the lungs are coming in, the arch is coming in, and they go so fast. They see there's the dissection right there, and they just keep going. Right. And I'm like, well, can you go back a little bit and show me where that is? So I think that'll be a really interesting talk with a lot of really good examples. And then to follow that is going to be Dr. Michael Duvall's mother, or Dr. Lucas Duvall's mother-in-law, Marta Chalinsky, MD. She is a radiologist, and she's going to bring in and do some basic X-ray reading for the perfusionist with how do you see where the balloon pump is? How do you see where the catheter is in the atrium? How do you know where all of these structures are so that you know how to look for them? What does a wet lung really look like? What does interstitial edema look like? What is that kind of stuff? What does ARDS really look like? What are we looking at when we're looking at it? So I think that'll be a great session with some really interesting information for all of us that we just typically don't do. And it may not really even be germane, except that you had a patient, you were in the ICU, and what was it you wanted me to show you? I forgot what it was, the catheter in the right atrium.
Trying to remember what kind of catheter. We had a veno-venous ECMO patient, and we had an Avalon cannula.
Right, and you wanted to see it on the X-ray.
There's no marker on
Right.
that cannula to show you where. I can tell you where the atrium is, but I can't really tell you where the outlet is of that catheter. So
Right.
what I did is I took a picture of it, sent it to Joe because they were there ready to move it if we needed to. And you could figure it out, but I didn't understand how to.
Right,
do it. And I'd like to.
I think it'd be useful for all of us.
Absolutely.
I think good, or even if you do understand them, I think it'll be good. Yeah. So that's going to be Saturday on the 24th. I think we're going to take just a 2 or 3 minute break here before we come back with our next talk. Is that right?
That's going to be a family show next week.
And it's going to be a family show, exactly. I think that's going to be great. So make sure you register for it. I haven't got the registration up yet, but I will get that done in the next couple of days, along with all of the other things that I'm deficient in, including getting any of you all your certificates that you may not have received yet. I promise I'm going to get that done, and I apologize in advance. So with that said, let's take a 2 or 3 minute break and then come back and get on with our next presentation.
Imagine trying to drive a car looking only through the rear-view mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. With other systems, periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt, or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration, or visit terumo-cvs.com.
And welcome back to the program again. We're going to go ahead and get right into my talk on alarm desensitization. Okay, very good. How would you like to listen to that all day? Oh, what happened? Huh? So what is the prevalence? Well, alarm desensitization or alarm fatigue. Hold on, we're trying to figure out. We've got technical trouble. That's okay, just leave them ringing. You know what?
Let it ring. He's desensitized. Those are his types of cases.
Let it ring.
It'll annoy me.
We don't hear it anyway.
Yeah.
Mining, the nuclear power industry, and of course, in healthcare. I want to read some of these to you. These are great. I'm going to read them all. Effects. The nurse went to check on the patient. Patient was put back on monitor. Patient was in asystole. A code was called and staff were unable to resuscitate the patient. Elderly female brought to emergency department. She was inadvertently off telemetry when she was found unresponsive and expired. A patient was admitted through the emergency department. Admission orders include telemetry monitoring. Nurse entered room and found patient unresponsive. A code was called and the patient was transferred to the intensive care unit. Later, the patient coded again and expired. Discovered that telemetry monitoring was never initiated on admission to the floor. A nurse responded to the patient's intravenous pump alarm and found the patient unresponsive and pulseless. Cardiac leads were found to be disconnected from the monitor cable. The physician was immediately notified and the patient was pronounced dead. So what are these continued effects? Well, in one 12-bed ICU studied, there were between 150 and 400 monitor alarms per patient day, which equates to, that's per patient per day, 1,800 to 4,800 alarm episodes in any given day. Patients were either in this particular unit, 1-to-1 or 2-to-1, and it was determined that each nurse in that unit was exposed to that number of alarms times all 12 patients each and every day. Well, the hospital is flush with alarms. One study done at the Johns Hopkins Hospital identified 59,000 alarm conditions in a 12-day period, or a staggering 350 alarms per patient per day. With all these alarms, it's no wonder that nurses and other healthcare professionals suffer from what is known as alarm fatigue. This is great. One notorious case involves a patient whose telemetry battery died. Before he went, oh, I didn't click it? Oh, sorry. Oh, sorry, let's start off again. One notorious case involves a patient whose telemetry battery died before he went into cardiac arrest. The telemetry unit quietly beeped for 75 minutes, low battery, beep, 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 before shutting down. Unfortunately, the man was found dead and cardiac resuscitation was never performed. Clearly, dead stiff.
Oh my God.
Dead for a while.
Yeah, bring
dead for a
batteries,
while.
yeah.
Well, the parameters, how does this happen? The parameters get changed. Okay, if the alarm keeps going off and the pressure is 100, I'm going to turn the alarm down to 90.
Yeah.
And then we're going to turn it down to 80. We're going to stop this thing from going off.
Balloon pump.
We silence them.
Yeah, we do.
Okay, we just the silence button, silence alarm. And sometimes you can silence them for indefinite periods of time.
Correct.
Okay, or we just simply turn them off. But the real killer is you just stop hearing them. It's going off and blaring, and you have just simply blocked it out. Why?
Yeah.
Because it's the boy that cried wolf. 85% of hospital alarms are false.
85%?
85%. Let that sink in.
Yeah,
85% of hospital alarms are false. Well, as humans, psychologically, it's the whole, Aesop's fable, the boy that cried wolf. We just don't even believe them anymore. We just start ignoring them. So in perfusion, in the OR, generally this is not really a problem for us as perfusionists. It is a huge problem for nurses. In fact, we'll talk about that a little bit, but there's initiatives on this. This is a huge, huge problem. Patient injury secondary to alarm fatigue is a very, very big, real problem that's being addressed right now with JACO and some other folks and the ECRI Institute, and we'll talk about those kind of going on.
Why do you say it's not a problem for perfusionists?
Well, in the operating room, we don't really have that many alarms going off. We're doing one patient, one procedure. It's a shorter period of time. It's a more intimate environment. Really, I think in the operating room, we're not, you heard that you'll hear it again as I move forward. I'm going to play it as my last slide. And hopefully this time, Roger, if you would, just turn it all the way up. I want everybody to really feel what it's like to have these alarms just blaring constantly, the IV alarm, the monitor alarm, the EKG alarm, the blood pressure alarm, the whatever alarm, the fire alarm, the this alarm. People don't even respond to fire alarms anymore.
True.
The fire alarm goes off and we're all just like, it's another false alarm.
Yeah.
What's going to happen the day when it's not?
Right.
Yeah.
It's real. Okay, so anyway, but You know, I mean, that's my view in the opera. I think we do have to be concerned about it. In the ICU, I think it's a bigger problem when we're monitoring ECMO patients. I think in those circumstances, you have all the other rooms going on at the same time, plus your patient. Which alarm is it? You know, you have to identify where it's coming from. What is that alarm? The ventilator alarming. Does that something I need to address? And I think that over time, you just become desensitized to all of these alarm conditions. So what is being done about this? Well, the Joint Commission is saying they'll take appropriate measures to reduce the number of nuisance or false positive alarms. Well, that seems to make intuitive sense. If 85% of them are false, it seems to me that, yeah, we need to address that issue. Clarify who is responsible for alarm notification and response. We could talk about that in the discussion period because I don't know what that means. Build a culture of safety. Well, that seems fairly commonsensical too. Carefully analyze and measure potential alarm-related problems. Well, again, that seems to make a lot of sense. And develop clear protocols for handoff communication. That really, you know, I don't know how that, I mean, this is what JCAHO is saying. Again, I'm not a JCAHO expert, but this sounds like a bunch of gobbledygook to me. It sounds more like the handoff communication is more relevant to us going when if we're having to be relieved on a procedure, and what procedures do we take for that? But there is something to say with that. I don't know, the handoff communication. You know, I've got bed 2, and you're going to be taking the patient, and Patrick, the alarms are going off all night, but I've just been ignoring them. The patient seems still to be fine. Good luck. ECRI Institute is also working on the problem. The ECRI Institute, I think they're looking for ways to have devices be able to interpret, is this a real or false alarm? But technologically, it's very, very complicated. It's a really big problem, but still does need to be addressed. And I'm going to go to my last slide, and I want everyone to really absorb this slide, and then we'll go into a discussion period, and you guys can call in, or we can chat, or whatever you want to do, and I'll go back to the YouTube chat to see. So here we go. We'll go to our last slide. All day long, this is happening at different times. And you have to filter all of that out. Alarm fatigue is a real problem. Of course, I don't have any solutions to it, but I think the one thing that I would suggest is we need to at least recognize that it is a real problem and not become complacent about when we hear alarms, because the likelihood, though slim, I don't think I could live with myself if I ignored an alarm and only to go in there to find out that it was really a problem.
Yeah.
So thoughts? I'll go to the chat, comments. Any of you guys want to elaborate on my content?
I wonder about, people talk about AI a lot, artificial intelligence, and you were talking about some of the organizations talking about making these devices more smart so that we don't have 85% of false alarms. And hopefully maybe technology could take that over a little bit for us in the future. But we still have an immediate problem with alarm desensitization.
Alarm fatigue.
Alarm fatigue,
I had a
that's
hard time
easier
with
to
that
say.
one
Thanks.
too. Yeah, exactly. Far fewer syllables. What's your thoughts? Is any nurses out there watching call in, or anybody who may be married to a nurse call in and give us some thoughts?
No, obviously it's a real thing. You know, even the surgeons get the fatigue, and at least they have the power in saying, like, shut that stuff off.
True. Isn't that true?
You know, I have a surgeon that I mean, he's got ears like a bat, and just goes off. And I go, well, that's for my purpose. He goes, well, it's not for my purpose. So he gets the fatigue, and you know what? There's a lot of times where I turn it to 0. I mean, I just have to be that much more diligent, and that it could be my pump, it could be the balloon pump. I mean, I do have that desensitization. I mean, it happens. It just happens.
You don't even hear it.
Yeah.
He hears it, but
He
you don't
hears
hear
it. No, I'll hear it. Oh, I hear it because I know that because the follow-up the follow-up isn't such a nice statement. You know, shut the blank off. So I'm sensitive to that versus an actual alarm. But so I'll shut off some of my alarms. The erroneous alarms, ones that won't affect my patient care.
Well, we have an ER nurse, you know, who's now a CRNA in the audience. As a matter of fact, here live in the studio audience, who's operating camera number, I think it's number 2. What are your thoughts? You want to call in? Sure. Oh, she can talk right here. Here, she can give you the microphone. So we have someone in our live studio audience. It's Vicky. She won't get in front of the camera though, but I could just have David twist the camera around.
I'm here. Can you hear me?
No, not yet. Oh, I can? Okay, good.
I have experienced the same thing Rodell's talking about, where in surgery the physicians, the surgeons don't want to hear the alarms going off because they get worried. They don't know what they are, and it may be that you have one of the 5 EKG leads disconnected, and it's going to alarm, but the EKG defaults to another lead, and everything's fine, and you can't reach down there right at that moment and reattach the EKG wire. But everything's okay, but they don't know that everything's okay. They just hear alarms. And any alarm to them, it doesn't matter which one it is worrisome to them. And
yeah, but they're there to protect the patient. I understand it's worrisome to them, but, you know, so
where's
Vicky,
the balance?
Right, but if
Yeah,
something...
I don't have the answer to that.
Yeah, I mean, everything to me, you know, has sort of changed a little bit, you know, now that I am not only a practitioner, but also a business owner. And I look at this from not just, of course, a patient safety perspective, which I think all of us that are in this room and those participating online are patient safety advocates. But, you know, so that's first and foremost. We have to do what is in the best interest of the patient. But secondarily, if something does happen and it is determined, and it's always easily found, that you turned the alarm off, even if that specific alarm was not necessarily the cause of the problem, where is your liability? Where's our liability?
Yeah.
Vicky?
I think anytime you choose to turn an alarm off, it's your liability.
Right, not the doctor's
Right.
who's doing the procedure who told you to turn it off.
Correct.
That's right. So that's where I start to get a lot of heartburn over this subject, because I think that is the common thread, that we just turn the alarm off.
Well, and this is just in my mind talking about alarms, but a lot of the surgeons like listening to their favorite tunes in the operating room.
Yeah.
And not alarms, and not having it interrupted.
And usually it's anesthesia that's responsible for the radio, so it's right over there on the anesthesia machine. And you know, if it was across the room, it wouldn't probably be as impactful. But sitting right on the anesthesia machine and to be loud enough for them to hear it sometimes overwhelms the alarms. And you know, and then you have to compensate for it. You have to turn your alarms up higher, and then they don't like hearing the or not the alarms, but the SAT monitor and the EKG monitor.
Do you not? I mean, those are really good points. So, you know, I'm a perfusionist. You're a CRNA. So but as a perfusionist, when I'm in the room doing stuff, getting ready for a case, doing my thing, while you have the patient asleep and they're opening the chest and taking the vein and doing the mammary and everything else, I still hear, when we're watching an echo in the ICU, I hear continuously that boop, boop,
Sure, right.
boop. And if I hear it going boop, 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 I know just from the sound, and I'll turn around and look to see what is changed, what's going on.
You prime a little faster.
You prime a little faster.
Right,
Prime a little
right,
faster.
right.
You're cutting into my break time
Oh,
now,
okay.
okay? That's not good, okay? Because I want my break, all right? I want
Right.
my break, okay?
Right.
But if you don't have that audible signal to you and the EKG that you can hear the heart rate, and how do you compensate for it? If they're blaring the music, you can't hear it, they don't want it on, how do you then have to compensate for that? Or do you?
Well, you if it's just one song that they want to hear louder, then you're watching the monitor the whole time.
Right.
If it's that they want to keep the volume up, then you move the radio, you move the sound system to the other side. If it's a really critical time and you can't, you're doing what you're doing and you can't just stare at the monitor, then you tell them,
Right.
I have to turn it down.
Mm-hmm.
I have to be able to hear the SAT.
You know, I'll tell you what, I turn a lot of alarms off, and I do it for the reason, I've never even thought about alarm desensitization, or fatigue, but I do that because then I have to watch stuff.
Right.
Because sometimes you rely on alarms, and I don't really trust the level detector alarm, honestly. I mean, sometimes it works, sometimes it doesn't. You know, bubble detector, same thing. So you really have to watch stuff, and I do turn most of the alarms off. Definitely the flow alarm and balloon pump, that thing's off the whole time.
Could you do me a favor?
Sure.
Stop doing that. Leave them
No,
on.
it helps me focus. I know
No,
that
I
I
really
have
need
to
you
watch
to- I
these
really
things,
need
and it
you
doesn't
to-
matter how
I-
loud the music is. You
No,
know,
I really need you to commit. That you'll never
turning
turn
the
them off
alarms on.
again.
But what if I get alarm fatigue?
We'll give you an extra day off
Okay, there you go. That's live there. You heard that.
Yes.
without pay.
Yes.
Forgot that part.
That's fine with me.
But isn't that a good
I've got
argument? I mean,
lots of
that's a
too.
reasonable thing to talk
Right.
about. I don't know how many people turn a lot of alarms off. I don't turn them all off, but I turn a lot of them off.
I turn them down. Like but again, Patrick's right. I mean, my scan gets a little bit better when I turn my alarms volumes down. The balloon pump, I get it down to its minimum alarm, and it's usually the augmentation alarm. And I'm sure all the perfusionists or whoever has run a balloon pump, knows how to do that, because that can always alarm at just erroneous periods of time, or when like the balloon pump is refilling or recalibrating, and that alarm can go off for many minutes, and you're getting a phone call from the ICU in the middle of the night, like, how do I shut this off, or how do I fix this? So, I do believe in alarms. It's just not very loud ones.
Of course, I'm older and hard of hearing, so I need them turned up real loud, and I try to watch really carefully, and I use Joe Basha, all of my alarms are on at all times, okay, and very loud.
Yeah. And,
Officially, it's on record.
Right. And it also alerts the surgeon of like the situation at hand. It's like, hey, my level alarm's going off. You know what, Doc, you got to fix that venous cannula.
Right.
I'm sorry. I can't keep going through this.
You don't want to hear this alarm.
You don't want to hear this alarm. Fix the problem.
Right. Exactly. Don't make me turn it off and suffer alone. I want you to suffer with me. I think that's a very good point.
Yeah.
Okay. Any other comments regarding that?
I don't think so.
Okay. So let's go right into Patrick on your presentation. I'm monitoring the chat, and we'll see what happens here. We're going to do a little experiment. And Patrick's presentation is going to be on checklists. Do they actually help? And just for the audience, just to let you know, we tried really hard to get an astronaut or somebody from NASA involved in this, because a lot of times checklists in aviation, but I think that having, somebody from NASA, I mean, that's kind of aviation, but it's sort of advanced aviation. But it didn't work out. But anyway, so I'm going to be monitoring the chat, and I think Patrick is going to have some requests too. Here, you need the mouse?
No, I just need to go back to the beginning of the presentation,
Okay.
because that's the end. Okay, there we go. All right, so there's no way I'm going to come down to on the side of that checklists are not important. I mean, I think that pretty much everybody could agree that they are. So this presentation is really about how effective they are, rather than are they effective. But it'd be great if somebody could call in and argue about that. That'd be great. Or if somebody in the audience wants to argue about checklists being a bad idea, that's fine. We can talk about that. But if you think about some of the things that we do, we build, not we, but people build an 80-story building, and the tensile strength of the steel is correct, and the windows don't fall out, and it works. In fact, the chances of a building collapsing, an 80-story building, is 1 in 50. What do I have here? 1 in 50,000 buildings collapse, and that's because, and that includes with earthquakes and everything. And the reason is checklists. I mean, everybody along the way, the architect and the people building the building and the people doing every detail of it are following checklists. And the way that complex tasks can get done, such as flying an airplane, and that's another good example, your chances of dying on a commercial airline are only 1 in 29 million. That's pretty amazing, because that's a very technical thing to do. There's people fueling the plane, there's people doing the safety checks. It's all checklists. So that's how checklists are related to industries that are not ours, like perfusion and medicine. But there is a very good example of a book that was written. It's called the Checklist Manifesto. And Dr. Atul Gawande is his name, and he started looking at checklists, and he's the one that actually brought checklists to the operating room, something that we're all very familiar with the timeout that we do, before we do a surgery. So he did a study. He works at Brigham's and Women's General Hospital in Boston, and he's a general surgeon and also an endocrine surgeon. And he did a study where they had a control group where they had no checklists, and then they did a study where they had a group of patients that were where they used a checklist, and the results were amazing. So just these numbers are really out there. Complications due to avoidable human error went down by 36%. 36%. Wow. And that's a big hospital there too, so that's a lot of people. Deaths went down by 47%, so half. I mean, that's absolutely amazing. And this was due to checklists. These checklists were written by the nurses and by the doctors themselves, so they made up their own. And he puts out in the book, he puts out some guidelines on checklists, that they should be short, they should be 1 page, they should be there should be a time that the checklist should be done. It's got to be laid out when the checklist is going to be completed, and it has to be quick and it has to be 1 page. So do checklists work? Definitely they do, and there's definite proof of that. So because of his book, and I'm not trying to do a book report, we are going to do a project here together in just a second, but because of his book, the World Health Organization started recommending the idea of using a surgical checklist, which we've seen this. Now the one we're familiar with is they recommend 3 parts. That there's a sign-in that's before induction, and Vicky's here. Do you do a pre-induction checklist for your patients?
Yes, we do.
You do, okay. So I've never seen that before, but what we all see is the timeout, and then there's a sign out that before the patient leaves the room, which again I have never been involved with that. Only the timeout is the part that I've been familiar with. So the main thing about this is that checklists are very important for mundane tasks, because something that we do every day, we can actually lull ourselves, and these are just some quotes that jumped out to me, while going through this book. When you do something every day, you can miss important parts, and when you've got somebody's life in your hands, you really don't have there should be no option that you actually go through the checklist and you look at the items. And I'll tell you, I have used electronic charting in the past, and the software that I was exposed to, believe it or not, you could go through the checklist, the pre-bypass checklist, and you could check each thing off, or there was a button that you could say yes to all. and it would go through the whole thing. And that's what we all do in our minds. Not all of us, but a lot of us do that when we're getting ready to go on bypass. We go through our checklist pretty much in our head, and we don't actually go through and do it. And I'm pretty sure everybody is guilty of doing that sometimes.
Not me.
Not you? So when you
I do all
when
my
you
checklists.
when you read
I
it,
keep all my
you go and you
life
look at it. That's great, and we should. And I'll tell you what, it was a case that you did the other
Yes.
day. You went through the checklist and you found something before you went on bypass. Remember
I
that?
couldn't remember what it was, but
It was
yeah,
it wasn't a big deal, but it was a
wasn't a big
sucker in
deal,
the
but-
wrong place.
correct. Oh, that's
It
what
wasn't
I found.
backwards
Yes.
or anything, but
It
it
wasn't
was, yeah.
backwards. It wasn't deleterious. But the fact was, I used the checklist to find it. It was in the incorrect raceway.
Right, right. No big deal, but
It was
could,
no big
it could have
deal.
been worse.
Correct.
So
Yes.
you're doing your checklist. That's good.
Yes.
So just a couple quotes. So whether planning to go to the store to make a cake, preparing for an airplane to take off, or evaluating a sick person in a hospital, if you miss just one little key thing, you might as well not have done this project at all. Because the check, and what really jumped out about that to me was, I love cooking, and I know you do too, actually.
Absolutely.
And you make a list before you go to the store, and you make sure you have everything. That's a checklist. It's a task list too, but there's not
Right.
a lot of differences between a checklist and a task list, except for a checklist is something that's the same every day, and it's to attack mundane. Not that perfusion is mundane, but it is a task that we do every day, and we can be lulled into a sense of safety. And believe it or not, this study showed along the way that you can actually think that you've done tasks and check them off on the checklist, but you really haven't done them. So checklists are important, and that's my point. So what I really wanted to talk about is, as perfusionists, where should we be using a checklist? And I think everybody is familiar with a pre-bypass checklist, and we use it. So that's item number one. But what I'd like to talk about, and hopefully some people will call in, or we can have some chat on the YouTube chat, should we ever have a handoff bypass checklist? How many times have you given somebody lunch, and you sit down and you take their place, and there's a clamp somewhere that you don't normally put a clamp, or there's a button, whatever. There can be a number of things, and I've experienced it. And I think you have a story about that, don't you, Joe? You took a case over, or somebody took a case
We'll put that
over?
in the discussion period.
Sure. Okay.
It's a little bit of a long story, so I don't want to interrupt your flow. Let me let you keep going, but remind me about it, because it's a tragic story too. So we'll talk about it.
Well, this is my last slide. I mean,
Okay.
I wanted to go. What I wanted, and the other idea I had for checklists is that some people are using termination of bypass checklists. And I think those are a good idea. There's only a few items that I would think of putting on there. But the handoff checklist, it'd be interesting to know how many problems there are when there's a handoff. And you think about if you're, at the ICU and you're watching an ECMO and you see a nursing shift change, they go through a process, and it takes about half an hour for them to go through handing off a patient. And I'm not saying we should take a half an hour as a perfusionist to give somebody a bathroom break or something, but I think there should be some things that we check off that we've looked at. Mm-hmm. Where are we at? Are we warming? What drugs have we given? What are the allergies of the patient? That sort of thing. So my idea was that if what we could do is potentially build a checklist together. So if there's people on YouTube chat, or if there's anybody who can call in, what are some of the items that we would put on that checklist?
That'd be great. Yeah, you got the call-in number up, already, and we'll do that. And I think it's great. So do you want me to tell this story?
Yeah, I'd love to hear this story.
I think you're really on point here. I think with something is that we generally don't give much of a report when we're relieving somebody. It's kind of like just where you at with the operation, and then that's it. And we all do things differently. We do things the same, but we do things differently.
Right.
Where clamps are, like you said, or what's going on were you having trouble with the pressure or not? I mean, there's so many things. If you did a full report, it's going to really, you have to come earlier for that break time. I think there needs to be probably a little bit more time associated with it. But there are some people, let me just throw this out, maybe somebody will have a comment on YouTube or call in, that people that advocate you should, if you start a case, you finish a case. You should never be relieved. And so there are people that believe that. I don't know, where do you come on that?
That's mostly how it's been for me. So I have the bladder of a bull, and you know, I can do cases all day and not have to take a break.
Right.
But it's so nice to have a break when it happens, and you know, and so I'm not an advocate of that. I don't think that's realistic. But I know it's the reality in many cases. People work alone. Yeah.
You worked in a situation when you were working in more of a single place institutionalized environment. What was your experience with giving breaks?
But we had backup. Yeah, absolutely. But see, we would never utilize it. Or at least I wouldn't, and it wasn't frowned upon. But you know, we just didn't really access it because, you know, it's again the continuity of care.
It kind of was frowned upon.
It was frowned upon.
Yeah.
It was.
Yeah.
Let's just say
What?
it was.
You need a break?
Yeah, right. It's it's kind of that Iron Man mentality. I mean, so but nonetheless, I mean, it's a continuity of care. It's not it shouldn't be a demonstrative type thing or just like a view on, you know, you can't do a case by yourself.
Yeah.
But it's a continuity of care thing.
But I'm sure that there is an inherent added risk when you hand a case off to somebody. I mean,
Absolutely.
There absolutely is.
Yeah.
No kidding. And I think that is a big problem. So not just on the bypass period. Okay, so even
Good
though
point.
we have this issue of
Right.
we don't want to return the case over, okay, we're going to finish the case, we come off pump, but you know, it's time for you to go and you've got an appointment or you've got a date or whatever it might be, and I need to go, and somebody comes in after you're off bypass, kind of to close for you,
Yeah.
so to
Right.
speak, okay?
Yeah.
So this is what happened. It was a pediatric case. They
I don't know if I want to hear the story.
Right.
I do want to hear the story. I do.
Yes.
and I think this is this has a lot of lessons involved in it.
Okay.
So the perfusionist was going to be relieved. The relieving perfusionist came in the room. The perfusionist who had done the case said, "We're done. All you need to do is clean up." He left. The perfusionist that was relieving
Lord.
took it literally. Took all the clamps off of the pump.
Cannulated?
And started throwing it into the trash can, but the baby was still cannulated. So as you can imagine, the outcome was poor, and it destroyed 2 careers. And you know, it's one of those. It's basically what you're talking about.
Yeah.
We don't have a handoff checklist. We have a pre-bypass checklist, but we don't have a warming checklist, a cooling checklist, a what to do if it's an emergency checklist, a termination of bypass checklist. We all know to kind of look and see, is the ventilator moving, and if it's not, are we breathing, you know, say something pleasant so that it reminds them, as opposed to, you know, turn the ventilator on, idiot. You know, we try not to do that too often unless we don't like the person, I guess. But, you know, nevertheless, when we're being relieved, we sort of give, and everybody does it differently, and the information that's transmitted is not uniform in any way or consistent. It's going to be different each and every day with each and every person, and I think that those kinds of problems can occur. So why don't we do this exercise? We'll just do it together, and nobody calls in. So far, we haven't gotten a call, but let's just do it together. What should we look at?
Is there a way for you to make a document to keep up with what we have?
I can do it right
Okay.
now.
Well, so I'm going to have to picture the situation. I don't have a pre-formed list. I thought we would come up with it as we go. So I would say, let's say you're going to walk in and you're going to relieve me. Already, I tell you, you know, where we're at in the case. I say, you know, this is coronaries, the distals are done, you know, and we're probably about to start warming. That's about all I say. So I guess, first off,
What would I like to know?
what kind of case is it, and where are we in the procedure? That would be item number one.
I want to know something about the patient.
Yeah.
What is
Yeah.
this patient? What's
Yeah.
this patient, you know, condition? Is this a small patient, a big patient? What's the size of the
Sure.
patient?
Well,
Is
that's
it a
on the
male
chart,
patient? Is
or
it a
that's on
female
your
patient?
pump
Have
record,
you given
hopefully.
any transfusions? Have you I mean, this list could start getting really long, and I think that's really the issue.
Yeah.
Let's do this, and I'm going to try to do my best with this, as best I can anyway. But again, we have a nurse in the studio audience. Let's ask the nurse. Is there a specific set of things? And now the nurse is eye rolling, and I can see it. Okay. Let's ask, what do they do when they are changing shift?
That's a great question. It is a very good question. It is.
On the spot here, I don't have a list in front of me, but it was similar to the things that y'all were just describing. Number one, the procedure, the patient, where you're at in the procedure, because that has a lot to do with how long the patient's gonna stay asleep, and what kind of medications you need to give for reversal, or do you need to start turning your gas down? Where you're at in the procedures.
Well, I'm talking more
important.
about the ICU. I'm talking more about the ICU. So.
Oh, and I think it your same thought process transcends the location that you're at.
Okay, fair enough.
Your basic
accept
your
that.
basic question, your basic request of what you want to know is tell me something about the patient.
Mm-hmm.
What's how old are they? What's their and I know it's usually always written down on whatever record that you're immediately working on, the day's record or the procedures record. And you can briefly just, pass through all of that. But and that's not going to change their age, their diagnosis,
Right.
All of that. But I think what's going on right now. Where their drips are at, what different medication they're
Mm-hmm.
on, what's in line next to happen. Do they have labs that are due? Do they have Accutane? All of the things that they're gonna immediately need needs to be communicated.
So I guess the first item on our list would be, you have a list going. That's good.
He does.
Where are we at in the case? I think that the stuff I look over, I hate walking into a case in the middle of it, honestly. I really don't like that, because you don't know.
I don't either.
You're not
don't have the feel
tuned
for it
into
either.
it. Yeah.
Right.
As perfusionists, I think the same thing with anesthesia. We have a feel for the procedure.
Right.
We have
Yeah.
we have been on pump for an hour and a half, maybe 2 hours, or if you're getting relieved, 4 hours, and you definitely have a sense of what's going on with this
Right,
case.
you-
And you walk in cold on that, and it's like it's hitting you all at
Yeah,
once,
yeah.
and it's very hard. How long does it take for you to do a change in staff, either in the ICU when you're caring for patients there, or in the operating room when you're doing anesthesia? But try to extrapolate that into higher acuity patients, more like heart patients or major vascular procedures versus, a hip replacement.
Well, I think the sicker the patient is, the more that's going to be going on with them, and the longer it's going to take, because you have more to communicate. If you're in a healthy patient elective surgery, then there's not much to communicate with them. They don't have all of these extra diagnosis to have to go through. You have a 20-year-old that's having a knee scope, then it's it's pretty quick. It's just what's going on with the procedure. In ICU, they're sick patients, and they have a lot going on with them. And like Rodell was saying, it takes 30 minutes, and it's a process. It's because you don't want to leave anything out.
Right.
So it takes so you're saying it takes 30 minutes.
I think it can.
Give,
Up-
so it can
upwards.
take up to 30 minutes, basically, is what you're saying. So it could take 15 if the patient is basically just sort of on autopilot, post-op heart, they've been extubated, They've got a little bleeding out of their chest tubes, but
Well, and that's
stable
and that's if
development.
nothing's going on at the time. It may be that you start report, because if you're talking about 30 minutes, you may have to stop and you may have to do something, and then you may have to come back to report and then stop and do something again, and then
Right.
it may take it. And usually you would have 2 patients, so
Mm-hmm.
you're you could get out of there 30 minutes, an hour late a lot of the times.
Just trying to get report.
Yeah, yes.
Right, and
exactly.
that therein lies the, nursing is tough business. I'll tell you what.
Absolutely.
It's a tough business. Perfusion's a tough business. CRNA business is a tough business. Medicine is tough, I think, anymore. I mean, it's just so complex, and we're doing so many different things that the idea of out by noon with no balloon or leaving on time,
Right.
On your shift is just something that doesn't happen. Is that, you think that's more of is that a newer phenomenon, or has that been basically going on for a long time? We're all pretty old here. My recollection of things is that's been pretty common over all of the years that I've been in this. You have any experience with that?
No, I think it's been pretty common through time.
It's not anything new.
Right.
Yeah.
Yeah, nothing new.
So, this is what I wrote down. For
Yeah,
what
I'd
you
like
were
to see
saying.
what you have. Is that something that can be
So I
shown
need to
too?
share this online, so hold on a second. Roger, do I need to be on the Mophie? Okay, so I'm gonna switch to that. Okay.
And I'm thinking kind of
And then I have to
technical, like
restart the software.
look over where are clamps, what's the
Yeah,
vacuum
right.
at? If there is
Oh, I
vacuum.
have to restart. Okay, it's on.
Where is the patient cannulated? There's a
And
lot of
I'm on
things.
There's a lot of things.
Yeah.
And there, do you see it? It'll take 20 or 30 seconds for
Yeah.
the
To
web
pop
see
up.
it, but it'll pop up. And I can change it while we're sitting here
Right.
and do it right now.
So what do you have on there so far?
Well, let's wait until, let me know when it's up. Is it up?
There we
go.
Okay, good, there it is. Okay, so where are you at in the procedure? About the patient, the demographics and the labs and other information regarding the patient's condition. What the patient's need for medication has been or will be. What's currently happening. What are the drips and meds that they're on? What are the hemodynamics? What are the labs? Have they received any transfusions? Do they need to receive a transfusion? So that's
Yeah.
what I have so far.
So basically, it's conveying your care plan
Yes.
to the next perfusionist or whoever the next clinician is going after.
Well, could you see that list? Do you have anything to add to the list? Let's create the list, and then
Well-
it'll be forever on there, and some people can add to it. Maybe they can add comments to the YouTube video later, because it's always up.
Yeah.
And they'll be able to look in there and make comments, and actually, people have been commenting on a lot of our stuff
Right.
later. So they might not be watching it live and wanting to contribute right now,
Right.
but they can do it later.
Those are good things, but I think that the list should be pretty specific. I think it should say, have you checked where any clamps? Just look at all the clamps. How many clamps are on the bypass circuit?
Right.
Is the cardioplegia line clamped? Who knows what's clamped? It depends on who you're relieving. Is the
Right.
vacuum line clamped?
Right.
So where are clamps is pretty specific. I would say, and what's the ACT and when was the last ACT? That's important.
Right.
And when was the last heparin?
Yeah.
Right.
Last
And this is stuff
administration.
you can look at. We could generalize that and put that, have you looked at the chart?
Temperature.
Oh, temperature. Yeah. Are we warming? Are we cooling? Yeah, that's a good one.
Yeah, because if it's been an hour since the last heparin and the last ACT was 20 minutes ago, and we've already heated up from 28 degrees
Sure.
to 36 degrees, we may want to do an ACT right now.
Right.
I mean, I don't know what your guys' level of charting is, but if Patrick has seen my chart. And
He's a good charter. He's a good charter.
Well, and it's funny. I write down very important details, and I will go back to the next perfusionist, or if somebody needs to relieve me for some weird reason. I like to finish my cases. I will actually go over every single piece I've documented, and you know, talk about my care plan and things like that. So you know, we are discussing everything that's on this list. So from temperature all the way down. So like, hey, this is your CRNA, you know, this is your anesthesiologist. This is not your normal CRNA. They're just giving a break or things like that. I mean, I'm going through everything, even all the way down to personnel. You know, I'm kind of detailed when it comes to that. I really don't like giving up cases, but you know, if I have to, I'm giving them every piece of information that I am trying to collect and, you know, return it to the next clinician.
I think that's the safest way to do it. But let's go back to the pre-bypass.
I think add personnel to your list, because I think that's that was an
Right.
important
Add what?
personnel.
Personnel who
Who were the people in your room?
Yeah,
Is that 2 ends or
that's 2 ends.
personnel in room? Okay.
I mean, you know, I think it's probably more common. Most people, and I'm with you, I would prefer to finish a case, and if I really need a break, take it right after we get off bypass.
Right.
But there still should be that checklist, because, you know, what happened, what the story you told, I mean, you were off, whoever the perfusionist was off bypass, and they said, this case is done, they left.
All you
And
need to
then
do
the
is clean
patient-
up. See, that was the key.
That
Yeah.
was the key. I know this story. I've heard this story.
So, you know, had there been a checklist, even though, so it's not only when you're on bypass, it's after bypass. I mean, it's certainly a critical time for the patient.
Absolutely.
At that point. So maybe even more critical than when you're on pump. So, you know, I think a checklist like this would be very helpful, you know, to us.
So why don't we do this? Why don't we commit to this? Why don't we, over the course of the next several weeks, months, whatever it might be, start developing this as a routine item to have and talk about it, and do this again where this is the actual topic. Maybe do it during the weekday. I think sometimes during the weekday, I'm trying to figure this whole thing out. It seems like we might have better participation during the weekday, people
Yeah.
calling in, than during the weekend. Though we look good. We did pretty good today. Like to do better. Pass the word on if you're watching. Claire, John, whomever. It'd be great to have, you know, more people calling in and being a part of this process. But maybe we just need to do this. You're talking about specifically a change of clinical staff checklist.
Right.
And why don't we just do that and redo it? And redo just that part.
Yeah. Actually, I also think you mentioned it. We were talking about charting. We could do an episode and maybe include it on this one as a chart review.
Yeah.
Look at some people's charts, not mine.
My
And,
handwriting's terrible.
And talk about, you know, what should be charted and what isn't charted. I mean, there's a lot of debate there.
But are there
And with electronic charting coming,
Right.
you know,
Right.
Of course.
this
And
is
are
the
there
top.
right? And are there standards for that?
Yeah.
And the thing about the electronic charting is, you know, that's a whole other topic, but that costs money.
Oh, absolutely.
Okay, electronic charting costs
not
money.
cheap.
It's
Yeah.
just like EHR or EMR that currently exists. But the thing is, the physicians who sign up for it, the hospitals that sign up for it, all these people that sign up for it are given these huge chunks of money to do it. But
Right.
we're not given anything.
Nope.
Yeah.
But yet it's much more expensive. I mean, these things, well, you know, you used to work for the company. How much,
Yeah.
I mean, it doesn't matter what company it is. How expensive are these things?
It depends on how many machines, you know, how many pumps you have and all that, but basically it's going to cost $50,000 to set it up and get it going.
Wow.
And then a lot of the companies will charge you on a per case basis. So, and that'll range between $40 to $100 per case.
Password to continue.
I don't know what happened there. So it's expensive. I agree with you.
I didn't recognize that.
I'm
Could
just
you
going
tell
to
me
turn
your
this
password?
off. I'm not going to tell anybody my password.
Tell 'em,
Are you
tell
guys
'em.
televising
Yeah,
this?
it's just the World Wide Web. It's just internet. It's just between us and the internet.
That's right. Okay. Anything else we want to add to this list while we're thinking about it? I think because We're a little bit early, but I think it's going to be okay for us to probably. We've had so much. We didn't take breaks. We didn't do anything. It's been really packed full. I think ending a little early today is probably not going to be a bad thing, and it'll help with you getting to relieve Stephanie. Stephanie, if you're still watching, please again forgive me. I'm not sure which camera Stephanie is in right now, but I'll look at all three. Please forgive me. I will never plan having our faculty be on call ever again. That was my mistake. Please forgive me. And with that, I think don't forget the program for the 24th. Roger, do you want to throw that? Can you still share my screen?
Yes.
Let me show you this. So here it is, Saturday, March 24th. We have the basic TEE, how to read CT scans, reading chest X-rays for the perfusionist, including identifying catheter and device placement, and then also discussions and call-in. Please also go to our perfusion perfweb.us website. You can see it up here on the screen right now. It's going to have, I'll be adding it has the 24th on there. I'll be adding more into this schedule. As a note, if you want to watch a program, this button right here, Watch Webinar Now, makes it very easy. If you go to the Schedule tab and then you click on it, it'll say Watch Now, making it very easy for you to do that as well. And I think, and the New Orleans Conference, let me give a little plug on that if I can. Let me go to theneworleansconference.com and come on, it's going to do it. There it goes. And some real exciting things that are going to be coming up with that. As you know, our award recipient this year is going to be Dr. Tyrone David from up in Toronto. We are approved for, and I'll throw these credits up here, 22.5 ABCP Category 1 CEUs, 20 contact hours for nurses, and 20 AMA PRA Category 1 CME for physicians. There's opportunity to become an exhibitor. There's fun things to do in New Orleans while you're there. You know, this is the tricentennial of New Orleans. I don't know if you all knew that or not, but New Orleans is celebrating its 300th year as a city.
Really?
So this year, this entire year, the French Quarter is just going to be a buzz with fun and enjoyable activities, including music and drinking and more music and everything that is New Orleans. So,
Is New Orleans known for that?
you know,
Oh,
it's just for the tricentennial.
Just for the
tricentennial.
Understood.
Don't forget that we have the drawing, which is going to be a week's vacation accommodation at a beautiful condo in Vancouver, Canada. And you get this by visiting the various different exhibitors. Also, we have some really interesting talks this year. Something I want to show you though. I want to highlight this special presentation, The History of Wine by Dr. Devinder Bhatia. Now, this guy has been on, I don't know, Wine and Cheese magazine, I don't know, whatever their connoisseur magazine is, but I just know if you drink it and it tastes good, it's good.
Yeah, right.
This guy knows wine. And also, Dr. Jones is going to be talking about nutrition and cardiovascular disease, and also alternative medical therapies. And of course, they're going to include in that wine as a medicine, alcohol as a medicine, but there's a lot of interesting stuff, I think, with that. We're also going to be doing some live presentations from remote locations using the Visitor One robot. So the New Orleans Conference this year is going to be a really, really good, interesting meeting. If you haven't already signed up for it, I highly recommend you do. But for those colleagues that need additional credits besides what you can get from the New Orleans Conference, or you can't get to a meeting but still want to participate, have great content, learn something, and earn those CEUs, continue to come back here to us at perfweb.us. With that said, are there any closing comments, Patrick?
No.
That's a lot. That's short and sweet.
Well, I don't have one.
I don't have any either, honestly. No. I don't
Are
have
you guys
anything.
enjoying yourself?
I am
Yeah.
enjoying
It's like pulling
myself.
teeth.
I am, but unfortunately I'm on call, so I can't really bask in this rewarding experience.
So it's been stressful for you both?
A little bit. I won't lie to you. I mean, I already had to answer the phone, so yeah. That's all.
Okay. Well, I've enjoyed it because I'm not on call, okay? So I've really enjoyed it a lot. And we've all enjoyed having all of you here with us. Can't thank you enough for being part of the process, and we look forward to seeing you all on the 24th. With that, we're going to have our ending video that Roger's going to play, and we'll see you all on the 24th. Thank you very much.